because I don't know it by heart. I think it's, hold on, what's in my Teams? Wait 1 second.
Okay. All right, Rachel, you might want to just
Okay.
yourself to Rachel HitLab or Rachel Fredman HitLab, just like Jan has done.
Oh, okay. Yep.
Video, and I'm going to.
Hold
I'm
on.
just going to get this started with the video, because otherwise we're going to be here forever waiting for him. I'm just going to have to wing it if.
Okay. I just sent it to you.
Okay.
Okay.
Hey, Stan.
Hi.
How's everyone doing?
You're doing okay. All right, I'm gonna get started with the intro video, Stan, and then you come on as it finishes off, and I'll start the webinar. Everything else is live in terms of YouTube and stuff. So I think we're good to go. You got the show flow?
I did. Thank you for sending that over. I'll go off video.
Okie dokie.
Jerry, how do I change my name now? Or do I have to sign out and then sign back in?
No, if you
No, you just click your name and then at the bottom it says rename.
Oh, really? Hold on. Let's see why mine is not giving me that. Nope, not saying it. Oh, wait, here. Yeah, I can't. I don't have the option to do that.
Actually, you know what? I'm just gonna bypass the video, guys, because we're running late. So we're just gonna have to can the video. We'll just go straight into it, Stan. Right bang, like smack bang at 11, I guess. Then. And then everything else is on the show flow. Hopefully everything is in the correct order, which it should be. But otherwise, it's just speaking to the slides and then going into the first interview, basically. Perfect.
Looking forward to it. Great work, guys. Looking great today.
No, thanks, Stan. I'm going to share screen and I'm going to let everybody in. If you want to give everybody like 30 seconds, I guess, and then start off with your usual good morning, good evening, and good afternoon to everybody.
Will do.
All right. I'll be on chat if you need me.
Sounds good. Hey, Rachel, you should go off video. I think they're going to see you possibly if you make any noise in the background. Here we go. All right. Welcome everybody to the July HitLab Digital Health Symposium. And looking forward to having everyone join us today to talk about healthcare access and equity. My name is Stan Kishnowski. I'm the director of the Digital Health Program at Columbia Business School, chair of HitLab, and visiting professor at the Indian Institute of Technology, New Delhi, India. And I'll be your chair for the session today, which will be focused on driving access and equity in healthcare using digital technologies and tools. And the program today is packed, and it would not be available today, would not be possible today without the special sponsorship and funding provided by Digital Diagnostics, a leader in the healthcare ecosystem in providing AI the right way. And so we want to pay special thanks to them for their support in today's programming. We do want you all to remember that this is not only a free program, but it's also something that's been done in conjunction with a number of partners around the world, including the Merck Global Health Innovation Fund, Medidata, the world's leading clinical trials solutions company, TeleView, one of the world's leading AR/VR surgical support companies, One True Health, a digital health company focusing on helping folks in long-term care and assisted living facilities, Colgate-Palmolive, whom you all know, and of course, ACHA, the America's Continental Healthcare Alliance, which focuses on helping people around the world understand healthcare better. So again, many thanks to our partners, and we want to make sure that everyone is going to be able to join us in this type of Zoom environment easily and comfortably. So please do be sure to join us for a meet and greet and continued discussion with speakers and attendees in the Zoom link available in the chat box, and join us there. And if you have any questions or comments during the program, during this, please do connect with me on LinkedIn and let me know your thoughts and what you'd like to see either in the sessions today or in future symposia that will be presented on the last Thursday of each month over the course of the years to come. And again, looking forward to getting your thoughts and having you included in those sessions. Our special guest today and a special component of what we're doing today is Donato Tramuto, a longtime healthcare leader in the United States and around the world. He's also very active with the RFK Foundation for Human Rights, and he's the founder of Health eVillages and the president of that organization as well. It's a not-for-profit focused on helping bring digital technologies to some of the world's most remote villages in some of the world's lowest income countries. And again, this double bottom line book that he's put out recently and published recently is truly transformational for leaders in healthcare and in digital health. And so we have, as he has generously donated copies of his book and personalized copies of his book, we have a giveaway. So the first attendee who correctly answers the next question in the chat box will be the winner of the first copy and the first giveaway, personalized giveaway of the double bottom line. And the chat is, the question is, healthcare spending in the US accounts for what % of the GDP? This is where you type in your answers in the chat box, and the chat box lights up like a Christmas tree in December in Rockefeller Center, and we have a number of answers. The correct answer, of course, is B, 19.7%, and growing fast. So congratulations to, looks, I can't even roll the chat box up that fast, but it looks like Jordy is the winner. Congratulations, Jordy. Jerry Antomato, the producer of the symposium, will be in touch with you to help you with getting your copy, your personalized copy from Mr. Tramuto of the double bottom line. We have a packed schedule today, so we need to get going here. And I'm really glad to have our first guest today, Blair Hurst, who's the founder of the Digital Health Review, a publication that everyone at HitLab has grown to love and read all the time regularly. And to talk about, again, some of the major issues around access and equity in healthcare and how digital is either helping to close those gaps or is, in fact, expanding those gaps. And we've seen both during the pandemic. Blair, great to see you again. Thank you for joining us.
Hi, Stan. It's always a pleasure. How are you doing?
Doing well, thank you. And how are you and where are you these days?
I'm doing okay. I'm still in Brooklyn, New York. I'm surviving the heat. Just enjoying time with my family this summer.
That's fantastic. Yeah, well, good. That's good to hear. And it is definitely a tough summer to keep cool. We've seen everything around the country and what's happening there. First off, for the audience that doesn't know you, again, most of our audience does know you. You've done so much tremendous work in healthcare over the last several years, particularly in digital healthcare. Could you let people know, first of all, tell us your journey and what you've been doing, particularly over the last few years with the pandemic, and how digital health review plays into that?
Absolutely. So I've been in healthcare for many years, and I've spent over 10 years actually building products for patients and clinicians. And so I have become dramatically aware of the impact and use of technology in the healthcare system and the many benefits that it has. But I've also had an acute understanding of the health inequities that have existed in the healthcare system far beyond my time, and that currently exists right now. And so I started this work in digital health review in part, one, to address those, but also because when I became a potential consumer of digital health, one person who is building it, one person who knows about it, I came up against barriers in actually accessing it. And so the first goal was really to, one, educate myself, and two, in the education, try and educate others. That was part of the publication or a newsletter that you were just mentioning that we have. And the second part was, as I began to understand and knew about all the digital health, but particularly the consumer health technologies that are out there in the market, I wanted to share that knowledge with others so that they could then have an easier time in navigating that. So that's really the origin of why I started Digital Health Review. And it's really to address some of those inequities, because as we have learned in the last few years, there is a decline in use of primary care providers or access to primary care providers. Actually, only 1 out of 4 Americans don't have access to a primary care provider. And so that is for a host of reasons, but it mostly affects Black and Brown individuals, those who live in low-income communities, as well as healthcare deserts. And so not having access to a primary care provider obviously leads to poor health outcomes. And the benefit of digital health to reach across borders and states and to disseminate the access of providers to those who have traditionally not been able to have them is a great benefit of digital health.
That's spot on. And maybe you could expound upon that a tad more as well, and talk a little bit about the benefits that you've observed with digital health and the impact it's making on women's health, particularly given the recent ruling on Rob and its impacts on Roe v. Wade.
Yeah, absolutely. I'll probably go back to some of the research that has already been done. So Rock Health, which I'm assuming most of the folks here are very familiar with, studied and published the fact that 2 out of 3 digital health consumers are actually adopting online health information tools. So that's above wearables and telemedicine. But what that effectively is doing is increasing the health literacy of the general population and helping them understand first what their healthcare options are, and then empowering them to choose what is best for them. And what we've recently seen also in the pandemic, and it was published in a study out of Penn Medicine, I believe, was that the rise in telemedicine has essentially eliminated, in some cases, the racial health gaps that have existed. So it's pretty clear through research, it's pretty clear through the use of telemedicine or use of other digital health tools, that there's a direct link to improving healthcare access and health inequity in the system. Right now, there has been a lot of attention post the Roe v. Wade decision or the overturning of Roe v. Wade about what's happening in women's health, and as there should be. And the benefit of women's health specific companies that have been founded and the dollars that have been spent in this area are going to prove essentially critical at this point. Companies like Shoe Health and Pandia Health that are providing remote birth control and abortion care options are now going to be on the forefront of consumers who live in states that aren't allowing for abortion care services or have restrictive services around birth control. And so the ability for folks who are in these areas that are now struggling to find care around a critical bodily decisions are going to have access now. And it's going to be extremely important that the dollars that are flowing to women's health companies doesn't dry up, that investors are doubling down on this and helping to grow more women's health companies in this space.
It's truly stunning, isn't it? And I think, at least for the HitLab audience here and for the folks who are following HitLab, it's important to understand from the medical technology perspective and the evidence base that we're following at the lab. This is going to be the greatest contraction of medical technology in U.S. history. So this is a major issue on many levels, and people are covering many of the issues around the human rights efforts here and the human rights consequences. But we've never seen a constriction of medical technology availability like this before in the United States. And all we know is that the ramifications of this are highly asymmetrical. We do not know what the public health ramifications will be. And at HitLab, we're trying to really get in front of this and understand it as much as possible from the adoption of technology standpoint. But Blair, you nailed it. It is really a major consequence. And I think that just to wrap up, kind of one final question, if you could please talk a little bit about some of the current methods that are being used to reach a lot of these underserved communities and really the deserts that you talked about, and what you've seen, which efforts you've seen really be the most successful. Aside from telemedicine, you've talked a lot about that, but some of the other digital interventions that you've seen applied in these areas, and whether it's the deserts or low-income areas that have been successful in closing some of these gaps.
Absolutely. I think outside of the interventions, I think the delivery method is going to be more critical here. So what we're seeing is a lot of companies are trying to define and distinguish themselves as culturally competent care facilities or culturally competent care tools. So companies like Health and Her Hue or Zocala, which is focusing on Latino wellness visits, She Matters, which is focusing on bringing Black maternal health into the conversation, Hurdle, which is working on culturally competent mental health care. All of these companies are trying to say one thing: we understand who you are, we're going to speak your language, we're going to meet you where you are. And that, I believe, is the first hurdle, because what we're fighting against outside of the restriction that may be happening post Roe v. Wade is the need to gain consumer trust. And the first thing that we know is that if we can speak the language of the folks that we need to reach and meet them where they are, we're more likely to get them to not only use, but adopt and engage with these tools in the long term and improve their health outcomes in the long term. We're also seeing efforts in improving at-home care. So reducing barriers such as transportation for those folks who live in healthcare deserts and aren't able to reach hospital centers or clinics, bringing the care to them, bringing medical device or digital health kits to their home. And in that case, preventing some of the healthcare outcomes that are happening for those that don't have care next door to them. And so Digital Health Review is really trying to help these underserved communities discover and navigate their options so they can feel confident in finding products that are going to meet their needs so they can care for themselves or for their loved ones. And we're doing this in a variety of ways. We're trying to help them understand and navigate cost and reimbursement through our guidance, also helping with data privacy reviews, letting them know which companies have basic healthcare data protections such as HIPAA review, as well as those that have been clinically validated or have gone through evidence-based research, which we've known and have surveyed are key and critical components in getting consumers not only just use, but adopt these tools. And so there's a variety of methods that are trying to be used, that are being used to reach these underserved communities. And I think as time goes on, we're going to be seeing more of an outline and a metric for how companies are being built for underserved communities and standards around that.
That's fantastic. Well, Blair, thank you very much, and keep up the good work. We're really, really glad to have you back on the program and really appreciate your time today.
Absolutely, Stan. Talk soon.
Take care. Well, a great start to what will be, again, another over 2.5 hours of discussions around driving equity and access to healthcare services using digital technologies. And next up, leading a panel on this very same topic and really focusing on evolving the medical intelligence component of healthcare and the standard of care. We have HitLab's own senior fellow Paul Saunier, who's also one of the leading analysts at Frost and Sullivan and one of the global leaders in digital health thought leadership, who founded, again, the LinkedIn group, the digital health group on LinkedIn with over 100,000 members there. And we'll be hosting a panel with Sid Khandan from Stel and Ravi Kumitareddy from Daytona Health, and looking forward to this enticing conversation around what's happening. And remember, everyone in the audience, this is a wide open chat box. Don't be bashful. Introduce yourself to the community, post your LinkedIn page, and talk, at least give your, if you could, give your name, your location, title of yourself and your organization where you work, and maybe what you're binge watching or binge reading or binge cooking. I don't know, but we'd love to learn more about our audience as we're diving into these sessions, because obviously, and we'd love to hear any ideas people have in the chat box as well, because the need to drive access and equity in healthcare has never been more imperative. And to lead the next panel around that is Paul Saunier. Paul, thank you for joining us today.
Thank you, Stan. Great to be here. Another great event you've got rolling so far. So thank you. Really delighted to be joined by my friends today, Sid Khandan, CEO at Stel Life, and Ravi Kumitareddy, CEO at Daytona Health. And a little bit more about me for folks that don't know, I am the founder of the 100,000 member digital health group on LinkedIn. So while I didn't coin the term back in 2012, I was the first to identify it as really the accurate description for what's happening with technology, digital technology and genomic technology, how it's transforming our world. And of course, we saw a lot of adopters of that term, fast followers, a lot of organizations taking hold of it, running with it. And so now we see the term digital health is widely used across the world, which is fantastic to see. So I recently joined Frost and Sullivan as a industry principal focused on healthcare and life sciences. And I'm currently working on a study focused on the digital front door, apropos this panel that I have with Sid and Ravi. And basically one of the first things I did was similar to digital health, is work on a definition. The digital front door is, in our vernacular, people think of it just as a website and say a portal to your EHR for patients. But really, it's much more than that. It's actually the virtual manifestation of a healthcare organization. And you could look at this analogous to how I define digital health as the convergence of the digital and genomic revolutions with healthcare, living, society. So it's much, much bigger than we think about. And I think that's critical for healthcare to keep in mind and kind of avoid the myopia, of, hey, we are only healthcare and that's all we do. That's our lane. No, we are much broader than that. And we have to look at the whole person, their health, their well-being. And that's where the digital front door comes in. And so that's why it's so wonderful to see what's happening in this area. And of course, Sid and Ravi are both innovators in this regard, doing some fascinating work. And so with that, I will hand it over. And if hopefully we have Sid, and yep, there we are. I see your guys' videos. So Sid, why don't you go ahead and introduce yourself and tell us a little bit about your company, please.
Sure. Thanks, Paul. Thanks, Dan. Hey, everyone. I'm Sid Khandan, CEO of Stel. Excited to be part of this conversation. I think as Stan, Blair, and Paul have mentioned, over the last couple of years, innovation has really forced us to confront the real question of, as we move forward, who do we risk leaving behind? And post-pandemic, health systems and care teams are being pushed to implement equitable digital health strategies that are accessible and non-burdensome to staff. Learn from the pandemic that the digital divide is real. 43% of lower income Americans lack broadband, and 60% of medical facilities outside metropolitan areas lack broadband as well. 41% of Medicare beneficiaries lack smartphones. And even if they do have smartphones, there's a real question about passwords and security, especially when last year we found out that the top 30 mobile health apps were hacked. So with all of that, it's no wonder where we've seen headlines that 75% of health system leaders aren't happy with their digital health strategy, and only 6% of health systems have a full-fledged digital health strategy. So our mission with Stel is to simplify digital health infrastructure for patients, care teams, and digital health companies. We patented a passive and secure health device connectivity standard that allows patients to connect to their care team without passwords, Wi-Fi, and smartphones or apps. They simply need a hub like this, which has no buttons or switches. You just plug it into an outlet, and you can use any Vitals device within 100 feet, and our hub will passively pick it up and send it over cellular right to your care team's EHR and preferred workflow. Just no password exchange. It just magically happens like AirPods. Paul actually affectionately coined our product Starlink meets the AirPods experience, so I thank him for that. For patients, they simply plug in their hub and they can use any devices. For care teams, the data shows up in their EHR preferred care platform. Seems that the chat says they can't see me anymore, so I don't know if the visuals are doing justice here, but the box here, they just barcode scan the hub ID into the EHR, and the data shows right into the patient-generated health data flow sheets within their EHR. So no new platform, no PHI risk, no customer data shared with Stell. And then for device companies, you can just throw our hub in the box with your product, or you can wait until our operating system is in patients' homes through the Echoes, modems, routers, and different systems that are adopting our solution. Since the start of the pandemic, we transmitted millions of vitals measurements from vulnerable populations and communities into preferred health system EHRs. And we're honored to build trusted infrastructure for visionaries at health systems, virtual care teams, digital health orgs, and device manufacturers across the world. So thanks for having us, Paul, at HitLab.
Yeah, fantastic, Sid. Again, a very unique solution and kind of the master key to the digital front doors, as we've talked about previously. And, it's really fantastic what you're doing. And, kind of on the other end of that is once we unlock that digital front door, what do we do with all that information, that data? How do we help patients to improve their health, manage conditions? And with that, Ravi, you have an excellent solution that you're doing at Daytona Health. Can you tell us a little bit about yourself and what you're doing there?
Yeah, absolutely. Thank you so much for having me on this morning. It's an honor to speak with all of you. Ravi Kamairedi, CEO of Daytona Health down here in Southern California. So we look at health and healthcare a little bit differently. And we're a consumer health company, and we're trying to match what I think all of us really want, which is the term we use is health span. Our company is focused on maximizing health span. And to us, that means really two pillars. One is preventing in the first place, definitely improving or reversing chronic disease. And we treat chronic disease as a cluster because they're so related. So everything from stroke, heart attack, diabetes. Sometimes in healthcare, we get so busy treating these as separate entities, but we know that they have common causes and are tied together, and we treat those root causes. The second pillar of health span for us is living longer, but living well. Thriving. And I think that's what we all really want. And to do that, we take a very functional medicine approach. So again, looking at the root causes, but inevitably we're led down to the path of behavior change. We just feel that those decisions that people make every day in sleep, exercise, nutrition, mindfulness, stress control, relationships, these things really matter. And the data shows and supports that they matter just as much or even more as the pharmacology that we're pushing on people, right? You can't be giving people Lipitor and then having them eat McDonald's 3 times a week. Like that's not a healthy future for anybody. So what we do to solve this problem is we take a multimodal number of coaches, everything from executive coaching, life coaching, but also health coaching. That team takes data from behavior change science, which we've codified, but also very personalized data from the kinds of things that's coming from Stell, wearable information, medical information, but a lot of psych profiling, motivational interviewing, really trying to figure out what makes you tick and what levers we can pull to help build you a system that we can coach over the course of 4 to 8 months, essentially upgrading your, not just habits, but your routines in health, sleep, exercise, nutrition, but also in work performance and relationships and time management. We've seen incredible results with our early cohorts, everything from reversing diabetes and putting it into remission, from people getting promoted, from people achieving these goals that they've always wanted to in their life and been limited by either their weight or disability or problems with movement. So it's a whole body experience of change that lasts throughout the episode of life, whether they have chronic disease or whether they are trying to prevent it.
Yeah, and Ravi, I love what you're doing. As we've talked about numerous times, it's really, I think, disruptive to the traditional healthcare model. And kind of coming back to what I said about healthcare needs to lose their myopia. And what you're doing is saying, look, here's what we can do to help improve the health and well-being of patients and consumers, and really, impact disease prevention, not just focus on, disease management and treatments. And so I really love that. And so really kind of on that note, when we look at what's happening in digital health broadly, Sid, maybe you can talk about what you see as, the problems you're tackling and the innovations you see coming forward in the future.
Yeah, so we have the fortune and privilege to support various digital health care teams and health systems. We're in about 8 health systems from Lehigh Valley, Tower Reading, Yale New Haven Health, Jefferson, Temple, Medical University of South Carolina, Hawaii Pacific Health, and Tampa. All of them are using us in different solutions, from their FQHC, hospital at home transition of care, to remote patient monitoring initiatives. So we see a lot in slew of the various programs. I think, as Ravi pointed out, there's that human factor. That if the patient is loyal to their care team, you can see that they'll actually adopt and change their behaviors and habits. Usually what gets in the way, though, care teams care about patients at home. It's just the workflows and institutional systems that limit their ability to do that at scale and efficiently. And so we're just trying to tackle away at these small nuances that add burden and extra steps in the process. And by doing that, I think we are able to create programs at these health systems that go from tens of patients in a pilot to thousands of patients in a full-fledged program. And it's really exciting to see that evolution when that happens.
Yeah, it's interesting when you mention, institutional challenges and I guess existing structure. And so, Ravi, I think that's something maybe you might want to touch on, and as you answer this question as well.
Yeah, it's interesting. So I think there's two things here worth noting. So one is when I look at like what a primary care physician, the number of patients they see, and the kind of touch points they have with care team, or their care team has with a patient. Let's do an honest accounting. Like, let's look over the year and see there's over 500,000 minutes in a year. How many minutes on average do you think a PCP spends with their patient over a year? On average in the United States, it's about 60 minutes, 60 to 70 minutes. And then there's other care teams that may touch base too, maybe a nutritionist every once in a while or something like that. But when you really think about it, most of these health decisions that we all make happen in those minutes where we're at home and at work. So the majority of our health is actually being determined by things we do at home and at work. So we have to be better about delivering behavior change solutions at home and work. I think that's a burden that's just not what the healthcare system is really good at doing, right? I mean, nowhere in my school I know how to do that. But that's okay. I think health is a team sport, and there are other experts that we need to start pulling in and passing the ball to. Like, if we really want to make this a patient-centered solution, that means passing the ball to dietitians, to personal trainers, to health coaches, these people that really understand motivation and behavior change. And that's not to diminish the role of our healthcare system. We're really good at putting stents in and breaking bones. We're not so good at delivering these therapies that are necessary. The other pillar on that is we've had 20 years of digital health, and a lot of people listening here will know when it wasn't called digital health, when it was wireless health, or when it was just the quantified self. And I see a market full of education, recipes, exercise videos, data, wearables. There's 4,000 apps, 1,500 wearables, 280 million smartphones in the United States. Directionally, that's not everybody, but it's getting there. So are we all really thinking that a lack of data is the problem anymore? Is that what's getting in the way of people's healthcare? Or is it really helping people stay motivated, meeting them where they are, unblocking them, and kind of unraveling or fixing this Rubik's Cube that is their life so they can actually maintain the right behaviors and take the right meds to stay healthy? So I think we got to move from the age of just information into the age of precision behavior. And that means turning all this data that we have into action. So I see companies like us as that missing wheel of the digital health car, if you will.
Yeah. I think both of you are highlighting that healthcare is becoming consumer centric, right? This trend of healthcare consumerism, we saw it accelerated with the pandemic, telehealth, people could not get into hospitals, and really, enabling this new paradigm in healthcare is key, and the benefits are profound. And so I think, I love what both of you are doing. You're both creating this new future, and really thank you, Ravi and Sid, for joining us on this call.
Thanks, Paul.
Thank you so much.
Stan?
Yeah. No, thank you, Paul, as well, for running such a great panel. Thank you. Fantastic. Well, it's I love that phrase that was mentioned, that healthcare is a team sport, and it really is. And I think when we think about healthcare and life sciences as well, when we look at those two ecosystems working together to not just create new interventions to help patients around the world, but also be able to find ways to deliver, disseminate, diagnose, et cetera, using those It's absolutely critical. So again, phenomenal job, Paul Sonia. Thank you for that. Next up, a tremendous scholar we have from us today from just up the river from Columbia University and the University of Albany. And very happy to have join with us here today a professor who has been doing a lot of work in digital and is an associate professor within the Health Policy and Management Department at the University of Albany. And again, we'll be discussing with us some of the issues that and some of the tenets that he's uncovered in equity and access in digital health. Professor Kwan, nice to meet you.
Good morning, Stan. Thanks for having me this morning. It's really my pleasure, to join this July symposium.
Yeah, thank you for your time today. We know how busy you are. If you could let the audience know a little bit about your background and your journey to and through and what you're doing at SUNY Albany.
Sure. My name is Johnson Chan, and I'm an associate professor of health policy and management at SUNY Albany. My research interests are healthcare technology assessment, real-world outcomes research, and healthcare disparities. To answer Stan's question, I did come from afar. I received my medical education and did residency training in heart surgery in my hometown, Shanghai. Then I flew to Singapore, did my master's study in clinical science, followed by obtaining my PhD degree in health services research and policy at the University of Rochester. 10 years ago, I joined SUNY Albany as a faculty, and 5 years ago, I got promoted to associate professor. More recently, I also did my business training at Columbia Business School, where I had heard great things about HeLab. So I stop here. Any questions, Stan?
No, that's a great background, and certainly just a reminder to the audience, we have live Q&A, etc. Or again, just linking with me on LinkedIn as well. I'm already talking with a bunch of folks on LinkedIn, including Gus, and appreciate the comments and the questions people have coming in there. But one of the things that we want to cover at the start of this program today is a definition of digital health equity, and how have you seen that defined in the literature, and what do you see as the best definition for digital health equity?
Achieving digital health equity means not only ensure access to digital infrastructure, but also designing digital health solutions with a broader range of users in mind, implementing in ways that address the unique needs of patients. I want to point that it is very important to understand the difference between digital health equity and digital health equality. Most of the people at first glance think these two words are interchangeable. However, these two words have very different meanings and implications. Digital health equality means to treat all patients the same way, the same manner, whereas digital health equity means to treat patients according to their unique needs. For example, personalized, custom-tailored digital health solution. Some of you might have seen figures illustrating the difference between these two concepts. One of the most commonly used one is that different individuals with different height, they need a different number of boxes for them to step on so that they can see over a wooden fence to the baseball field. And other figures using bicycles, different size to meet the needs of different individuals. To achieve digital health equity in the real world setting, it is recommended, at least according to the latest literature, to consider the following 5 different domains of social ecological framework. First is the individual domain, such as digital literacy. Second is family and home domain, for example, private and secure place. Third domain is community, whether you have trusted community-based organizations and digital capacity. Fourth domain is services, whether digital training and technical assistance are provided. And finally, I personally think is very important is policy domain. This can be happening at global level, national level, state level, and local level. I just want to mention, global level, you can consider WHO, UN, they have the roadmap to improve digital health equity. In the US, we have the DHHS, they have multiple initiatives. And one recent example is from New York State. They set up this broadband initiative statewide and even local level, like a county level. And policy literacy is something relatively new compared with health literacy, digital literacy. But I personally, observe and also think this becomes increasingly important for all stakeholders to succeed in the digital health space.
That's a great definition, and thank you for that kind of detail as well. I'm sure the audience really appreciates that. And one of the components that have been covered, or one of the components of digital that's been covered over the last 30 years of research in this area, has been around this idea of information symmetry and information asymmetry, so that not all people in the global healthcare system, in even the U.S. healthcare system, receive information in a symmetrical fashion. So that's one of the components that we've paid close attention to at HitLab, and certainly it's good to hear you bring that up. And part of what you talked about in the definition of digital health equity was this notion of inclusion. At least you did have this nuance to what you're talking about there. So now talk to the audience a little bit more about digital health inclusion, and what does that mean to you, and what should we take away from that term?
A good question. So according to National Digital Inclusion Alliance, NDIA, it is an acronym. Digital inclusion refers to the activities necessary to ensure that all individuals and communities, including the most disadvantaged, have access to and use of information and communication technologies. This actually includes 5 elements. First, affordable, robust broadband internet service. Second, internet-enabled devices that meet the needs of the user. Third, access to digital literacy training. Fourth, quality technical support. And fifth, applications and online content designed to enable and encourage self-sufficiency, participation, and collaboration. Digital inclusion has become critical to promoting healthcare equity. Remember, in 2021, there was a law called Infrastructure Investment and Jobs Act. It makes investments that could foster sustainable digital inclusion. It includes $65 billion for digital inclusion initiatives. It also emphasized a community-based approach to digital inclusion by enabling state-based grant mechanism. So I want to mention in New York State, we have one statewide initiative with over $1 billion. They want to work with community partners to solve this broadband access issue. And it is worth mentioning that some of my grad students actually are doing internships related to that work. And at the same time, there are 21 million people in the US do not have broadband access, which definitely constrain their use of telehealth. And I think, a combination of progressive digital inclusion efforts together with digital health policies could lay a good foundation for technology-powered healthcare equity.
Yeah, and again, I think that we're just getting to the point of winding down our time here, but really wanted to thank you, Professor John. Thank you very much for joining us today.
Welcome.
And we've had now, we think about the role of digital in healthcare as what was originally meant to be a way of helping improve equity and really access, and it has done that in a lot of ways, but it still has a long ways to go. And having some of the definitions of inclusion and digital health equity provided to us here, it was just fantastic. We have a phenomenal duo coming up next of people that two individuals who have had a lifetime of commitment toward healthcare and toward specifically also implementing digital in a rational way in healthcare to address the issues around access and equity. And Lisa Crimes is a Senior Innovation Fellow at HitLab. Hi, Lisa. Thank you for joining us.
Thanks, Dan. Always great to chat and have these conversations, especially an important one for us to be talking about.
Really is, really is. And joining Lisa today will be April Smith-Harak, one of the leaders in the HHS, Health and Human Services for the U.S. government, and working and leading a lot of what's happening out of the Northeast region. Hey, April, how you doing?
Hi, great. Good to be here, Stan.
Good, good. So Lisa's going to lead an interview with April now, and we're going to hear a lot more about what's happening and get that perspective from April around access and equity from the governmental side. Thank you, Lisa.
Sure, absolutely. Hi, April. So great to chat with you again. This is, there's so much for you to share, but I thought we would maybe just start with you sharing a little bit about your journey to being a regional health administrator for HHS.
Sure. Well, I'm a little bit of a weird fit for public health. I started out as a PhD in psychology, and I studied social psychology. And my doctoral thesis was about stereotyping and discrimination, and what types of stereotyping lead to discrimination. So I actually have a very long history in equity and equitable health and other work. And over the course of the years, I went through CDC. I ran a bunch of different areas there, and then came to the region about almost 13 years ago now. And I've been working for the last 5 as the regional health administrator.
That's awesome. That's a great path to get there for sure. Well, can you jump in and talk a little bit about the relationship between public health and health equity and access? I mean, how does all that come together?
Yeah, so in public health, we've been talking about equity, and it's taken various terminology forms over the years, but we went from social determinants of health, and we're moving forward in the equity space. So we're talking about health equity, and talking about public health equity is a little bit broader than digital and health tech. It's talking about the ability for everybody to achieve their best health. And that's really the mission of Health and Human Services. So it's exactly what we've always done. As we've moved into looking at digital health and emerging health technologies, the question is very interesting to us in the government of how can we ensure that emerging health and health modalities are founded in an equitable system and space. So, we didn't do the best job setting up our health system a gajillion years ago when we set it up. But we have an opportunity now as we're moving forward into next phase of health and healthcare to build a really equitable foundation, which would mean equitable access and a system that really uses this new technology and all these health modalities and new biotech knowledge to benefit all of society as a whole in a very equitable way.
That's fantastic there too. Well, what about I thought this was really interesting, but can you talk a little bit about how, the federal government basically invests in the resources and continuing that work of getting access and equity to care? And then I think we talked a little bit about health literacy, and you might want to, maybe if that relates a little bit here too, if you can tie that in or how that plays a part of this.
Absolutely. So we have a few pieces of that there. So we have, over time, we have invested in innovation in very different ways throughout Health and Human Services. We have many, many agencies that you probably all recognize and maybe don't realize are part of HHS. So we have the FDA, we have CMS, we have CDC, we have NIH. All of those are HHS agencies, and there are more. There's the SAMHSA, which focuses on substance abuse and mental health. So we really run the gamut. And then we have ACF, which is our Agency for Children and Families. It runs on the social services side. So there's many of factors of the social determinants of health and all of the ways that we affect health in our society. And each of those areas have always had investment potential in new and emerging technology. And we've done it in different ways. And some of the ways that we've done it most recently are through challenge.gov. We've issued challenges to anywhere from foundations to companies and businesses. We have had a longstanding SBIR and STTR program, which is Small Business Innovation Research Grants and Small Business Technology Transfer Grants. And those are amazing for early stage startups with new technology. And it's just a great way for companies to be able to develop their technology and their company in a more comprehensive way without diluting their equity. So we've always had that investment there. And we have areas that specifically invest in new and emerging technologies like BARDA. BARDA is in our area for the Assistant Secretary for Preparedness and Response. They're actually becoming an agency. This was the big news last week, is that it had been an Assistant Secretary level office, and they're going to become their own agency in HHS within the next 2 years. So they're moving towards that, finishing that transition. And within that entity is BARDA, which is the Biological Advanced Research Directives Administration. And so they are looking at emerging technology that could benefit us in something like a pandemic, like COVID, or perhaps would help in an emergency like a hurricane. It runs the gamut. And they make investments. There's a new program there called DRIVE, run by a lovely guy named Sandeep Patel. And the DRIVE program is a private-public partnership that's investing $500 million, much like an equity fund, in new and emerging businesses. And they take those really risky investments to help us get some really cool businesses with amazing potential over that hump in order to be able to benefit and really work in an equitable way. And then the last thing is we have coming up the ARPA-H administration or agency. It's the Administration for Advanced Research Projects in health. And so this is your cancer moonshot that President Biden is always talking about, but also it's health technology, it's digital health, it's all of these emerging things that have the potential to shift the way that we behave and interact with our health and healthcare system. And so that has just been started. It was just funded by Congress this year, and that's coming up. I don't know how we're doing on time, so I'm going to check in with you and see.
Well, we're doing actually pretty good. We're down to probably the last couple minutes here, so I could probably wrap it up with just one more question.
Sure.
If we want to end there, is those are great programs, by the way. I mean, it's so interesting to hear about all the things that are going on and just the wealth of all those resources. Can you also just talk a little bit about the necessity for an AI-based approach and how the data is used to optimize healthcare delivery, specifically how the HHS is approaching and addressing this issue?
Yeah, absolutely. And this goes back to that second part of your earlier question about cultural competency and linguistic appropriateness and things like that for equity across different platforms. So when we're looking at AI, one of the things that I love to talk with founders who are working on AI, machine learning based new companies, is to talk with them about how are you, if you're doing speech recognition, how are you analyzing for different accents? Can your program handle that? Or can your algorithm handle the fact that if you're using, a medical insurance claims database to base out your predictive algorithm, that insurance claims database is going to be inherently biased. And so how are you going to correct for the inherent bias? Because we know that the existing access to our healthcare system is not equitable. So if you're going to build on top of that an AI system that uses that as its background, then it is going to also be inherently inequitable. So we try to work with founders and companies to just raise some of those questions and hear what some of the solutions are. People have some really incredible, really great solutions coming down the pike. And so it's very exciting for us.
That's so great, April. Thank you so much. It sounds like there's a lot of great programs going on. We could barely touch the surface within 10 minutes, but it was a great conversation. With that, I'll turn it back to you, Stan.
No, thank you both. Yeah, thank you very much, Lisa. Wonderful, wonderful interview. Thank you for that. Outstanding. And so, again, just to review the agenda for today, I know it's a lot, and I know that everyone who is online, and again, we've got hundreds of folks from around the world, from, again, providers to patients, to life sciences, to pharma, to venture capital folks, government folks, just looking through the long list of folks who are joining us today. Again, number one, don't forget to link in with each other. If you could put your LinkedIn address and your name, title, and where you are, what you do, that sort of thing, in the chat box, so that everyone can get to know each other. Number two, again, link in with me if you have any questions specifically, so I can follow and message you on individually on LinkedIn. And then number 3, please do feel free to, if you have any ideas for future symposia topics, do let us know. Next up, we have Bishan Singh from Microsoft, and someone who's also done a lot of government work in his career. If you could look him up on LinkedIn, you'll see he's not only worked with the HHS, but also with NIH, and has a deeply rooted understanding of healthcare system. Hi, Bishan, how are you?
Hi, Stan. Great to see you. Nice to be here.
Good to see you too. And either you have an amazing kitchen or you have an incredible background for your Zoom filter. What is that behind you?
There's a nice fake background I have of this my favorite coffee shop.
Your favorite? Okay, there you go. I was going to say that looks very nice. Well, again, first of all, thank you for your time. We know how busy you are in this day and age. And second of all, if you could just provide a little bit of background for the audience, a minute or so about your journey into healthcare and certainly in digital healthcare.
Sure. Yeah. So I trained in neuroscience and data science and started my career studying behavior, learning, and memory while I was working on animal models in a lab. I'm fascinated by how the brain works, so my goal at the time was to better understand it. I learned a lot, but I'm not sure if I have more questions now about the brain than I did back then, so the journey continues. But after the lab, I spent a couple of years at the National Institutes of Health, as you mentioned, where my team and I were funding brain research. So this meant giving out grants as a part of the Brain Initiative, as well as to other researchers who were leveraging stem cells to study disorders like depression, bipolar disorder, schizophrenia, things like that. And my focus was really around the data integration component of these efforts, which led me to my next role, which was at the Department of Health and Human Services, just like April. So I worked on 2 main challenges there. One was incentivizing cross-department alignment of social determinants of health-related program dollars, and then enabling department-wide data sharing. So these, as April mentioned, these were and still are big problems to solve, and the efforts are ongoing. So imagine if you're at the CDC and I'm at the FDA, and we're both working on something towards figuring out a solution to the opioids epidemic. How do we figure out that you have this data set, I have that data set, and bring them together to do something more effective together than we otherwise would do separately? Along the way, I got an MBA from Georgetown University and landed at Microsoft, where I'm now focused on developing strategies for our clients in the health and life science space to leverage the cloud, Azure, and related tools in order to work more efficiently and intelligently, and while doing so, improve health at the population level.
Okay, that's fantastic. And, I think, obviously you're doing a lot with Microsoft these days around the digital transformation there. Talk a little bit about what that looks like and how that's impacting and how you think that will impact access and equity in the healthcare system 5 or 10 years down the road, given Microsoft's really pervasive impact on healthcare these days.
Yeah, so we're doing a bunch of cool stuff. So I'll start with the access front. So we're working towards enhancing some of the capabilities of ordinary sensors. So to take webcams, for example, to measure, let's say, like physiological signals like peripheral blood flow, heart rate, blood pressure, things like that, so that in areas and settings where medical devices aren't available, care providers can use webcams and maybe even their smartphone to assess a patient's condition, which makes access much easier. The same technology can also be applied in the case of remote care delivery. So care providers can converse with patients and get data on their condition simultaneously and without having to meet them in person to check their blood pressure. So this is a huge advancement that I'm really excited about. We're also partnering with other companies to leverage Azure as a platform for accessing and analyzing health data for use cases that connect with real world data. So let's say facilitating access to remote care, supporting decentralized clinical trials, patient matching, things like that. Nuance, which was a recent acquisition for us, can be leveraged to reduce provider burnout. HoloLens can be leveraged for more precise surgeries with the help of augmented reality. So bottom line is patients can get access to better quality care and therefore benefit from better health outcomes. And then on the equity front, one example that comes to mind is we're addressing important issues like why we see certain inequities in healthcare data. So I think someone mentioned this earlier as well. So machine learning methods, we're developing some machine learning methods now that make it easier to understand what machine learning models have learned and then provide tools to mitigate things like bias, which traditionally have made some of the health outcomes less than ideal. So those are a couple that we're prioritizing and that are really exciting to me at the moment.
That's amazing. That's really spot on and not surprising, just given Microsoft's long-term commitment to healthcare, going back to just supplying hospitals all over the country and really around the world with a lot of their real basic office systems, and then running the Microsoft Health Vault for several years, and then eventually just what we're seeing now with the kind of work that you're doing as well. And just to wrap things up, we've got about 2 or 3 more minutes here. What do you see as again, given all your work in the federal government side, as some of the major initiatives and really the major steps that the federal government is doing, either vis-a-vis the NIH or any one of those 24 agencies, or the CDC that we just talked about with April, or the HHS rather with April, and then even the CDC. And we have some folks who are listening in the audience from the CDC today as well, from Atlanta. What do you see as some of the major initiatives that are making a difference in access and equity for a lot of the folks that have just not been able to be really added to and be taken up with this digital health revolution that we've seen, particularly in the last 3 years? Yeah, that's a great question. So firstly, the 2 ARPAs. So one, April mentioned ARPA-H, Advanced Research Projects Agency for Health. And then the second one is the American Rescue Plan Act of 2021. So ARPA-H is still in the process of being stood up, but Francis Collins, the director of NIH, and others have already described in detail the need for ARPA-H to target vulnerable groups, not only because that approach is necessary, but also because that approach will likely improve care for all patients. So this means that there could be a shift in terms of the way certain patient groups are prioritized. So traditionally, when the largest or most strongly affected groups are prioritized, could now be moving to the most vulnerable or rare disease groups being prioritized. So that's an exciting shift that I'm seeing. So the other ARPA, just the American Rescue Plan Act, the one without the -H suffix, they're focusing more on the SDOH side of things, so social determinants of health. So funding community-based organizations towards advancing racial equity, literacy, whether that's health literacy or digital literacy, and other important factors related to access and equity. I think that's an important shift as well that we're seeing, and important work that the federal government is supporting. On the HHS side, some of my former colleagues recently created a new office called the Office of Climate Change and Health Equity. So I think, health equity at the intersection of X, Y, and Z is going to be a really interesting trend to follow. So this office's goal is to serve as a hub for climate change and health policy. And I think what they're working on is environmental justice and equitable health outcomes. So communities in areas where they're exposed to pollutants, where hotter temperatures, the risk of power outages, flooding, things like that, put them at risk for worse health outcomes. So I think that intersection of health equity with other trends is an important one to follow. And then lastly, I'll just wrap up with the private sector side. We see companies connecting social determinants of health data with clinical data. And this is a hard problem to solve because it's tricky to attribute the success or even failure of an intervention there with a change in a clinical outcome measure. But it's super important because if it works, then people like payers can create programs to prevent negative health outcomes and incentivize patients to take certain actions that'll improve their health. So it's an exciting time to be in the space, but then again, it's never not exciting to work at the intersection of health and technology. Yeah, absolutely. And again, thank you for your time today, Vishen. Just great comments and very insightful thoughts about what's happening with access and equity. Thank you. Thanks, Dan. So we are just trucking. That is the end of hour number 1 on this 3-hour journey here today to cover a number of issues in access and equity. And I really, again, want to appreciate the hundreds of folks who are tuning in from around the world. We know that you're busy as well. And by the way, we will drop in the YouTube channel for HitLab. If you miss any sessions today, if you can't make the entire program, don't be afraid to subscribe to HitLab's YouTube channel and to have that up and running as well. So you get videos as they drop afterwards. And then also would like to remind everybody who is at the symposium today, this is a special chance for you to enroll in the Digital Health Strategy Program happening November 20th through the 29th, excuse the typo. Again, September 20th through the 29th, the Digital Health Strategy Program. You can certify from Columbia Business School in the Digital Health Strategy Program at Columbia Business School. It is virtual, it is online, you don't have to go anywhere, you can take it from anywhere in the world. It is 11 a.m. to 2 p.m. each day, Tuesday, Wednesday, and Thursday only. So 3 days week 1, 3 days week 2. And you can enroll today for just $4.99. Again, we love to have people enroll from communities from all around the world. And we know a lot of you can really appreciate the $4.99 cost for a certification from Columbia Business School relative to the usual price of $5,450 to certify from Columbia Business School in the digital health program. So again, look in your chat box. Jerry has dropped into the chat box the instructions and the discount code, which is very important to use in the payment side of that transaction. And again, it's just for today. So do enroll today if you are interested. You can find out more about it online. Otherwise, again, feel free to email me or link in with me, and happy to send you more information as well. But we also want to remind you that there is a meet and greet after this session. So do, again, use the Zoom link that Jerry just dropped into the chat box as well for that meet and greet. Also, we have one more book giveaway. Pop in your answer to this for your own personalized signed copy of the Double Bottom Line from Donato Tramuto. According to the CVS 2021 Healthcare Insights Study, what was the most important factor for when engaging with healthcare according to US adults? A, ease of access, B, data security, C, coordination of healthcare provider, or D, healthcare costs. So again, you're the first one to answer this correctly gets their free digital health, their free copy, hard copy of the Double Bottom Line. Again, according to the CVS 2021 Healthcare Insight Study, what was the most important factor in engaging with the healthcare system in the United States for adults? Access, security, coordination, or costs? And the answer, of course, is ease of access, the actual title of this program here today. So again, the first one to enter that into the chat box is the winner of a personalized copy for the Double Bottom Line. Again, tremendous to see that happening. And then we have now, of course, at the top of the hour, a tremendous interview that will be taking place with one of the leaders of the US healthcare system when it comes to labs. LabCorp is, as most of you know, a household name when it comes to the lab systems in the United States. And if you haven't been following the news, it's also one of the leaders, if not the leader now, in mobile phlebotomy and getting your labs taken at home. It's also the first lab in the United States to have a home-based monkeypox test as well. So they've also done some very, very innovative strategic partnerships with folks around the country directly related to the healthcare system, including a very, very nice deal with Atlantic Care Systems in New Jersey. So again, LabCorp is just doing some amazing things, and great to have both Seth from Digital Diagnostics as well as Sharad from LabCorp. Thank you both for joining. Thank you, Seth, for moderating.
You bet. It's very nice to be back again, of course, Stan, and love all the things you guys are doing at HitLab. By quick way of introduction for me, I have the great pleasure of serving as president and COO at Digital Diagnostics, where I help a fantastic team to run and, of course, grow that business on a day in and day out basis. In terms of Digital Diagnostics, a little bit about the company. Our mission is to transform the accessibility, affordability, equity, and quality of global healthcare through the use of technology, and specifically through medical diagnosis and even the treatment process. And our flagship product, as some of you may know, is IDXDR, which was the first ever autonomous AI in healthcare that did not require a physician overread. And of course, comes with that unique ability to scale into non-traditional settings, which I think is a nice way for me to let Sharad talk a little bit about LabCorp.
That's great. That's fantastic. And Sharon, again, if you could give us a little bit of background on yourself as well and what you do at LabCorp.
Yeah, absolutely. First of all, I appreciate you guys getting us here. Really excited about this panel. Nice to meet you again, Seth. It's been a while. LabCorp and Seth have been connected at the hip for a while now, it seems. So yes, I joined LabCorp very recently, so I might not be able to provide a full perspective on everything we do. I've been here about 6+ months now. But broadly, my career has been in the healthcare industry last 20 odd years. Started off as a physician, mostly in intensive care units. Did some work with startups, actually brought a diabetes screening device, which was not as autonomous as Seth's. Seth's is way better. But we worked on that technology in San Diego in between 2012, 2016 timeframe. But since then, I've been mostly involved with the investments world. Last 4 years with United Health Group, and now with LabCorp. So it's really interesting. My career has taken me at all these different places, just getting a full perspective of healthcare. And I think LabCorp is one of those really interesting places which can affect people's health in so many ways, and where this whole concept of AI and leveraging autonomous AI really becomes really fruitful, and it enables health across the continuum in the US as we know it.
Yeah, it's fantastic. And I think, again, as we're seeing this, and as we're talking about digital and using digital as a way to improve access and improve equity in healthcare, we're reading so much and we're studying so much about how AI and machine learning can do that and help make things more affordable and more accessible and improve outcomes for people, not just in the US and some of the wealthier nations, but also the lowest income nations around the world as well. And Seth, lead us off a little bit, talk a little bit about, again, for some of the audience here, what is the definition of autonomous AI, and what are you seeing, and where are you seeing this? First, before we talk about the access and equity components of that, what are you seeing, and where are you seeing it have the biggest impact within healthcare right now?
Yeah, so I think it's a great place to start, as you mentioned. And for me, the best place to, or the easiest way maybe to differentiate is to first start with, I think most people might be familiar with stuff like clinical decision support, advanced analytics, any way that you have data, medical images, those types of things that are having AI applied to it in some manner, shape, or form, that ultimately then goes to a provider to make that diagnosis. We categorize, and I think the industry largely now looks at those as assistive AI. And there are, I think, of course, many good use cases for assistive AI, but important to differentiate, as you call out, Stan, a little bit different than what we do today. And that is autonomous AI is sort of the opposite of that, right? Which is, as I talked a little bit about what the company does, the important distinction there is no place in the process where once we have, in our case, medical images or high fidelity data, where those are then being sent and we're waiting for a physician to also review. That was what was so both groundbreaking and illustrative of what the FDA, as well as some of the other validation points, the American Diabetes Association, the NCQA helped us validate, is our autonomous AI is the computer actually making that medical decision or diagnosis for the patient. So we can, of course, get into the how exciting that is from a scalability standpoint, and in particular, how working with a partner like LabCorp might make that really interesting. And of course, then that leads into our topic for today of access and equity. But hopefully that's helpful as a definitional starting point to your question.
That's a great starting point to the question. And again, I really appreciate the not only the background and some of the connection points and some of the cases that you're seeing, but also the definitional components too. And Sharon, I think it would be great to hear more about what you're doing with AI at LabCorp and where some of the kickoff points are around access and equity there as well.
Yeah, and we all know, I mean, LabCorp has a really big sort of brick and mortar presence, right? Like 2,000 plus PSCs. So if you think about it, we are connected to a majority of the US population within, I think, a few miles of their homes. They can actually enter a PSC. Now, if technologies like SETS, if we could if we could bring together the infrastructure where deploy what we've already created with these new technologies that are coming up, deploy them in our locations. Now, even though in rural areas or areas where clinicians might be a luxury, for example, if this autonomous type of AI can be deployed in existing locations, now you've actually taken one layer of complexity away. Right now, you don't have to necessarily hire or keep clinicians in those locations because, well, we have an existing PSC, and now the patients can go in, get tested, get the right kind of diagnosis without the need for that clinician. So we have an existing infrastructure which we would like to deploy for things like this, right? And that's why we, through our venture fund, we continuously look at all sorts of investments where we might be able to bring them to our locations or broadly to people's homes, right? Because we have this on-demand kind of program. We invested in a company called GetLab so that we can take tests directly to the patients. As we think about all these various ways that LabCorp can get testing to the people, we want to overlay a new layer of technology or health tech or AI-enabled services that might be able to get patients information that they need faster, and then maybe if the clinicians are not needed, even better, right? Because, for example, if there's a way to reflex test based on what we just got, and the autonomous AI makes a decision, sends the next level of testing, now you've removed one step where there could be time delay and all sorts of things. So that's sort of what we're doing with our investments, and our groups at LabCorp are very interested in leveraging all the new modalities within AI, assistive and autonomous.
It's fantastic. No, that's really fantastic. And I know, Seth, before the session, just talking through things with you, there's a lot that digital diagnostics is doing to improve access and equity. Obviously, that's the core of the topic today that we're discussing in this symposium this month. Talk a little bit about what you guys are doing specifically to improve access and equity through your AI technologies.
Yeah, so for us, it starts with design, meaning if you think about putting an AI out into the wild that is potentially unsafe or in its design is potentially biased, you get into a really bad place really fast. So you might then appreciate our deliberate approach towards, and our tagline even of doing AI the right way is core to how we build our products. So for us, it starts with design, meaning we don't do black box algorithms where you don't actually know what's going on. We have good transparency, traceability, and good explainability for the algorithms that we build. I also mentioned before some of our sort of validation points or proof points there, meaning, as I referenced, we didn't just put this out and see how it went. We started with patient safety first with the FDA, and then we also worked with several other organizations like the American Diabetes Association, the National Committee for Quality Assurance, to make sure that what we were putting out was both safe and effective, and inherent or core to that is making sure that the technology is invariant to things like race, ethnicity, gender, et cetera, right? So that first bucket you can think of sort of as just designing products that meet that criteria, and we know are safe, effective for all kinds of different patients and patient populations. The other thing that I would mention that I also talked about a little bit around our mission is just the core of what we do is provide access. And so what I mean by that is, if you think about the years and the resources, the time and resources, the dollars that go into training up, for example, a provider to get to the point where they can actually make this diagnosis for a patient, we can talk about years and years and hundreds of thousands, if not millions of dollars to have that one provider able to help the patient in diagnosing, for example, in our case, diabetic retinopathy. For our technology, we spent obviously many years making sure it was safe and effective, and of course, a lot of resources. But now we have something where anywhere you have an outlet, you can plug in access to high quality specialist level care. And that, of course, includes, and I think as we're highlighting today, underserved rural areas, areas that really need some of that access. As an example, sometimes we overlay a map of the United States. And of course, we are looking globally, but in the US alone, in the Southeast, there is a very high prevalence of diabetes, and there is a lower number of ophthalmologists to test for diabetic retinopathy. So you have this supply and demand mismatch, if that is one example, where patients then ultimately wait 3 months, 4 months, 6 months to get in. And as you can likely expect, there are negative outcomes as a result. Patients start to lose their sight unnecessarily. And at the heart of that is an access issue for a variety of reasons, of course. So I like to highlight one example that happened recently for us that I think is a good way to illustrate some of what I'm talking about. We've been working more and more with FQHCs, federally qualified healthcare clinics. And there's one example in the Southeast where there are multiple locations. And in this particular group, compliance was very, very low, meaning the diabetic population, on average, not even 20% of those patients were getting tested every year to see if they were going blind, to see if they had diabetic retinopathy or macular edema. Additionally, about a little more than half of that population were racial minorities, and 95% of that population was at or below 200% of the federal poverty limit. So this is a patient population that has an outsized number of diabetic patients. They are not able to go get this test as they need it. And as you can expect, the outcomes there are not what we want at all. Within 90 days of us putting our technology into that clinic, we had doubled their compliance rate. And some people may say, well, what does that really mean? In the first 90 days, we found 30 patients that were in fact had a level of disease that needed intervention and treatment. And we were able to help refer those patients to get that treatment so they didn't go blind. So, in our view, and you can probably hear it as I talk about it, this is like core to what we do. And this is really making a difference in some patients' lives. And of course, we're proud of that. And we also see that this is absolutely what our technology is designed to do. So if that is helpful as we think about access and certainly equity, you can see that we are really trying to not just talk about it, but actually walk the walk.
Yeah, that's massive. I mean, that really is helpful, not only in the definitional sense, but also with some of the case studies that you're presenting there. And it's tremendous to see how far it's gone and I think where it's going as well. And certainly, sure, I'd like to hear more about the, I think at some point it'd be great to see more about and understand more about some of the elements that LabCorp is doing as well. Would you like to add a little bit there on where you're seeing AI really lead the access and equity charge within LabCorp?
Yeah, absolutely. And by the way, I don't know, my video is off, not because of me. I think somewhere on your end, somebody has switched it off. But what I would like to say on that point is I think two really important things, right? Seth brought up this concept of like making sure the AI is done right or the algorithms are built right. Like, so we are actively pursuing a lot of initiatives within LabCorp. For example, in the past, we've seen all the blood tests have these values. To some extent, they might differ by weight class or some of those. But for women, those values might be different. Those average parameters. For people of color, those might be different. So we, within our group, are actively taking the approach. And our group is full of these 15 plus PhD researchers who are working on making sure the algorithms that we use are sort of enabled for this kind of diversity. And we are going through all of our data sets to make sure we build the right data sets for that kind of population, right? So that helps with the trust factor. And I truly believe that if people don't trust their AI, then adoption is going to be challenging, right? So that's where it starts. And then what other things LabCorp is doing? For example, we are looking at this company, and we'll probably at some point deploy them in various rural locations, etc. Where, for example, a phlebotomist might be a challenge, right? Getting a phlebotomist. I mean, for example, now you just put these devices with automated blood testing systems, but now the blood blood collection system is also automated, right? So now all you have to do is just walk into the location, put your hand in, get the blood test, and then based on all the various other systems we've put in place, we can actually get you right from diagnosis to the treatment places without the need of anybody, right? So putting in place all of these sequential systems that can completely, maybe take away the need for people to, spend part of their days, which otherwise they can't, because oftentimes what we see is people who need the most care can't get to their doctors in time, or their schedules are messy. So we're trying to do away with a lot of those, and there's more similar initiatives in flight that I can discuss more, but I think we're running short on time, so I'll stop there.
No, it's fantastic. And really, thank you both for joining us today. Just a tremendous conversation, really illuminating a lot of what's happening within the digital diagnostic space, and certainly within LabCorp as well. Thank you, Seth. Thank you, Sharon.
Thanks for having us.
Take care.
Bye.
So we've really driven into the both the access and equity issues nicely in areas and in ways that are much more nuanced than you read on the daily news blurbs and things like that. We're really diving into the details around access and equity and digital health. And I think one of the things that we talk about when it comes to access is trust. And one of the key issues, as we've seen over the pandemic over the last 3 years, is trust in the life science system. And at the core of that life science system are the clinical trials solutions companies that are providing the backbone of clinical trials globally. And when it comes to that, cybersecurity and being able to secure clinical trials data is at the essence of that core. And there is no other way to say that, simply put, the most secure way to either collect or store or transmit data or analyze data is through blockchain. And the world's leading blockchain clinical trial solution, actually the world's only blockchain clinical trial solution, as far as anyone that we know knows, is BlockCube. And it's been a technology that HitLab has been studying for a couple of years now and seen it progress, and has just signed a major new contract with the CRO. And again, congratulations on that, Rama. But to interview Rama and to hear more about BlockCube is Dr. Alex Kahana, who works with the UN and advises them on a number of blockchain and cybersecurity issues. Alex, thank you for joining us again today, and thank you for taking on this rigorous and highly interesting interview with Rama Rao. Thank you.
Thank you, Stan, for inviting me. And I always love coming to the HitLab Digital Health Symposia. And I do share your sentiment that Rama has developed a excellent product that sure he's going to share with us. And I would start with, Rama, I've known you for years. I hear a lot about decentralized clinical trials. Every time I open the internet, I hear about it, and then I read that you have decentralized clinical trial management system. So could you just explain to me or explain to the audience, what is the difference when you say decentralized and when I read on other websites, what do they mean when they say decentralized?
Thanks, Alex, and thanks, Dan, also for this honor and opportunity. So, Alex, you're exactly right. I also have the same feeling as you. And I think that decentralized, the word has been, especially decentralized trials, has become a bit of a misnomer. So the interesting part is even McKinsey talks about decentralization of clinical trials, meaning you just take the trial to a patient's house. Now, what is lost in that whole process is the entire infrastructure of governance of what Stan talked about, data security, data integrity. And even more importantly, is the centralized control doesn't change. So the individual at the recipient of the decentralized trial is still a centralized participant. And our sense is that if we do not have decentralized software, it is really challenging to go to the full length of creating decentralized trials.
I see. Well, it's interesting because it almost feels like they should call it something else. I don't know, like direct to patient or home-based clinical trials, then use the word decentralized. But could you briefly elaborate? What do you mean when you say governance? When you say transparency and security, what does that mean?
Yeah, and if you really take a look at clinical trials today, generally speaking, COVID has, of course, created a huge acceleration. But generally speaking, we've had issues of data integrity. We've had issues of, ransomware attacks come for cybersecurity. You had issues that there are multiple systems. And on top of it, we also had issues of, different participants not getting financially paid because, you got batch processing, etc. Our approach to it from BlockCube's perspective has been that let's have a unified source of truth and then unify the modules that sit on it so they all talk to each other. So if you start using a blockchain and then keep the security totally intact, the data is immutable, and whether a trial is taking place in Nairobi, in Kenya, or in Boston, Massachusetts, because the data is coming to the blockchain at almost different time points, that's locked in so that there's no chance of any data integrity issues per se. And that's the approach that we have taken, or the strategy we have followed with our system. And it was really exemplified when we tested it out in a rural area of India, where we are doing an observational diabetes study.
I understand, and so just to make sure that I understood what you meant is that the decentralization makes the system more cyber resistant, censorship resistant, collusion resistant, and so the organization of the database, if it's not decentralized and it's centralized like all the others, then they are vulnerable for that. And in that case, tell me a little bit how that looks like in for example, in terms of equity and diversity when you did the trial, the truly decentralized trial in India.
So the first part is that even in the US, and I'm so glad listening into what Sharad and the other gentlemen spoke about from digital diagnostics about the rural population in India. In the US, 25% of America lives in the rural areas, and that's only covered by 8% of medical or institutional care. So there has to be a different way of reaching out to the people, right? So our approach has been that first we need an instrument like an iPad or an iOS system to take the trial to the patient, and should be intuitive and easy enough that either they or a lower level healthcare worker can use it. But even more importantly, use the cloud to really decentralize it from a geographical perspective. And then on top of it is to see that the data is flowing in real time. So in case there's any data governance or data integrity issues, it can be quality fixed much earlier. For example, in clinical trials, we often have something called a query, and we look at it like after the last patient has visited and the database is locked for the data statistician to work on it, how many queries do you generate? If you put quality upfront in a decentralized way and then lock it in appropriately, our hypothesis and our case suggests that it'll be much faster at the back end, improving the quality and speed of the clinical trial. And that becomes critical when you look at diversity and equity, because access, and there's a very recently a Greenfire study that was published also in Clinical Leader, if I recall correctly, and they talked about access as being a big issue. So we want to kind of make that access process a lot less onerous from what it is right now. And that's what we tested in an infrastructurally deficient area in India, or rural India. It was an observational diabetes study. And they had a protocol that called for 850 patients to be studied in 12 months. They gave us 150 patients and we covered them in 12 days. So even if we look at building up the software, training people, testing it, we must have saved at least 50% of time for the people in terms of running the process. And as Stan has said, that has also triggered the sign up of another customer, and we'll be doing a multi-country trial. So hopefully the guys will be sitting here in, whether it's in the Northeast, and watching a trial taking place halfway across the world in real time to see how effective it can be.
Well, this is fantastic. Again, what you're bringing to the participants of clinical trials, what you're bringing to researchers, what you're bringing to sponsors is just simply amazing. One last sentence, everybody. Why would we want to use this real decentralized platform and not the other decentralized direct-to-patient home-based platforms?
Great question. I think what we're trying to do is to future-proof systems. Today, healthcare, all of us are more like consumers of healthcare. If tomorrow we need to turn people into producers or healthcare producers, we need systems which are not centralized systems, but decentralized and owned by the people themselves. And what we're laying is the foundation. And once we demonstrate it with the clinical trials execution, then we'll start layering things like self-sovereign ID on top of it, federated learning processes, zero knowledge proof, so that we protect the identity of people, but the data then gets shared to accelerate the evolution of science and treatments for unmet needs.
Thank you. Thank you so much, Rama. Well said. From health consumers to health and wealth producers. Thank you. And thank you, Stan, for having us, and looking forward for next time.
Thank you, Stan, and thanks to the HitLab team also for this opportunity.
Absolutely. No, thank you, Rama, for joining us. And Alex, thank you for a terrific interview and wonderful session. So we are going from what will be, in our estimation, a disruptive technology in digital health on the clinical trial side, because that's how disruptive technologies are made. When you have something like blockchain as a new core technology stack come into an ecosystem that previous legacy and incumbent providers can't match because their entire platform is based on an entirely different technology stack. That's one of the key attributes to finding a new disruptive technology takeover. And so we're anticipating BlockCube as one of those technologies that will see substantial adoption in the ecosystem over the next 10 years. So well done, Rama, and thank you, Alex, for that. And we go from an access and equity conversation around security and how that drives access and trust in the healthcare system to a discussion now around data equity and accountability for digital quality measures and API machine learning and AI decision support. And we're extremely grateful to have two leaders in that ecosystem, Judy Keene from Novartis and Holly Varnell from Dream Big Healthcare. Holly and Judy, welcome. Nice to see you both.
Hey, thanks, Stan. We're very happy to be here.
No, it's great to have you. And first of all, how are you and where are you both? Holly, you can go first.
I'm actually out of Denver, Colorado, and I'm doing very good. I'm glad to be presenting on this panel.
Fantastic. All right, Denver. And Judy, how are you and where are you?
Yes, I'm also doing well, and I am in Silver Spring, Maryland.
Fantastic. All right, good. So let's start with some introductions and just a minute or so about your backgrounds and your professional journeys to where you are today. Judy, if you could lead us off on that, that would be wonderful.
Sure. So I originally started out as a research scientist, but I got into kind of this digital medicine when I was working at medical associations, medical specialty societies, working on precision medicine, big data, things we were calling that. And now that's kind of moved and morphed into digital medicine, AI, machine learning. I'm thinking about how associations what sort of role they should be playing in that field, and how they can engage and how their role is in getting it into clinical care and clinical practice. I then moved over almost a year ago to Novartis to do that from the other side. So now partnering with medical associations in digital medicine and thinking about what sort of partnerships and what sort of connections do we need to make and collaborations do we need to have to bring digital medicine into clinical care and clinical practice.
That's wonderful. Impressive journey, no doubt. And Holly, give the audience a little bit of background on yourself as well.
Yeah, so I'm currently the executive director and lead consultant for Dream Big Health. We are a consulting group that believes in driving reform and equitable medicine with big innovations. With today's innovative healthcare landscape, we're trying to help new vendors, payers, health systems get into the market or expand their market, or even make sure that their products don't hold algorithmic bias, which I'll get into a little bit later. All of this kind of stemmed from my last initiative, which was driving equity for maternal health and childcare. And I've partnered with like the National Institutes of Health with some large national leaders. And it's been wonderful just getting to know what we can actually do to start to solve some of these access and equity problems, and then trying to make a difference at the same time.
Brilliant. And again, really appreciate the time you're both taking out today to join us. And to start with, let's just start with some personal perspectives about some of the measures that you've seen that have been successful digitally to not only use apps that will help people manage their healthcare better, but also some of the digital health devices that you've seen improve access and equity for folks as Blair Hurst mentioned at the very beginning of the program, some of the folks that are sitting in low income parts of America, whether rural, suburban, or urban. And Judy, we'll start it off with you, if you could address that.
Sure. I think we're looking at, incorporation of all sorts of different devices and ways that we can do better data capture, reach out to patients better. What ways can we engage people in ways that we haven't before? And this obviously will just improve our data over time. I think, thinking about, wearables and those types of devices that are helping with detection of a variety of different endpoints in new novel ways, and seeing what sort of data insights we can get from that we've never really heard before. We've been looking at, how do we develop new digital measures, and one of the things we've been doing at Novartis is working with the Digital Medical Society and coming up with novel digital endpoints. We've been working on a program with them. It's much larger, it's not just us, a much larger program where we're looking at nocturnal scratch and what sort of endpoints can we develop with those that will help with patients with psoriasis. I think we are always looking for those types of opportunities, always looking for ways that we can incorporate new apps and new devices that will help improve our data.
That's a great way of kicking that off. And Holly, how about yourself?
Yeah, so I'm a strong believer in digital measures and what we can actually do with them as long as we're using them in the correct way. I created some clinical quality measures around access and medical management and actual change in medical management for maternal health, or started to last year. And it's that's really important. We need to ensure, one, it's focused on something that will actually make a difference. So an actual change or an outcome change at the same time. But making it digital, we have the ability to start to work on those things that we know will improve quality and access now, but also risk stratify out some of those data points as we're gathering this information to learn new points of care and new pathways that we can help and diagnose earlier and sooner.
Okay, that's exciting. Those are both exciting areas. And I think one of the things that we're seeing as well is apps and some of those data sources that are driving certainly easier access for patients. Not all patients, certainly some, is in this area of being able to standardize some of this data. So it's easier for the providers that are trying to enable these technologies for these populations to get that done. And I will start with you, Holly, this time. If you could give us some perspective and maybe some case studies around what we could be doing as a healthcare ecosystem to make it easier for major system stakeholders like hospitals, health plans, life science groups to enable this kind of data access to patients through having standardized these sorts of formats and forms. What do you think?
Yeah, so I think one of the biggest parts is making sure that the apps actually harmonize with the systems that the providers and the health systems are currently using. I also think that there's the ability to create interoperable or structured clean data when you're building these algorithms for some of these apps. So it's actually pulling accurate information so the provider can trust, what it is that's being told to him from some of this awesome new technology that's coming out that helps us be a little bit more patient centric. But also, I think that we need to start to look at some of the standards and giving guidance to maybe even the electronic health record systems and how they can vet through apps and pick through different remote monitoring devices that do enable better access to care. And just really trust, one sort of system on this is actually going to make a difference for my patients versus there's 20 million out there and they're all integratable with my electronic health record in my hospital system. And what do I do now? So I think it's really just coming up with a vetting process.
And Judy, what about yourself?
Yeah, I agree. I think, Holly, you're making some excellent points. I think the portability, what are ways that, patients are going to different hospitals or unfortunately having to go to different systems, how are they going to be able to bring their data with them and understand their data? I know I go on different portals for different physicians that I see and really kind of understanding what my data is and how, is there a way to be able to move that around? It's such a big issue. And I think what the efforts that the ONC, the Office of the National Coordinator for Health IT, are doing to make the interoperability part actually happen, I think are very important. Because I think, as you said, Holly, how do we have data available for patients in a way that they can understand it and then be able to have that be portable and accessible is really key.
Yeah, that is absolutely the cornerstone of the issue. Without a doubt, and without that, it really doesn't take off. And again, now starting with you, Judy, on this other issue that has been discussed throughout the day, but we're really holding out hope that artificial intelligence and machine learning and the algorithms that can come from that technology base will play a role in helping to either vet solutions or enable solutions that will help really respond to patients' needs and population health needs in a much better way, in a faster way, in a more efficient way. What have you seen along the lines of AI, machine learning, doing that thus far?
In terms of like vetting apps and getting standardization of materials?
Yeah.
I think we're starting to see that there's groups coming together to be able to address these issues. It's not just going to be something that comes from physicians or comes from patients or comes from payers or coming from the government. I think everybody has to listen to what are the needs and what are the gaps. And I think we're starting to see that. We're starting to see there's information coming out from the government, what their expectations are. There's patient groups and medical specialty societies that are starting to think about, okay, what sort of things do our providers need? What sort of things do our patients look for? What sort of questions and what sort of answers do we need that will satisfy everybody? It's not going to be one group coming up with an answer and then being able to just push that out to everybody and everybody will be happy. We really need to work on this together. And I think this is, there's an area for a lot of the specialty societies and the patients group to be able to have a very big voice to say, here's some of the things that we need. We are a trusted separate entity. Our interest is for the patients and for the providers so that we can get the best care to people. And, here are some solutions and here are some ways to vet apps in a non-biased way. And we have to also, as we're doing this and looking at, what sort of answers do we need and what sort of gaps do we have, we also have to think about, okay, are we propagating any of the biases that were already there and any sort of things that have been historical in the data? Are we just making it worse or are we just continuing it along as we're starting to move into these digital measures and a new way of looking at digital medicine? So I think that's all really important. And I think we need to start to do coalitions together to be able to make this happen. And I think we're starting to see that.
Brilliant. And we have about one more minute left for Holly. If you could answer the same question, that would be great.
Yeah, no, so I agree with everything Judy said. I think that we're coming together as groups and starting to incorporate like Z and V, ICD-10 codes for relational codes and social determinants of health, new value sets for that, and really trying to focus on specific populations. One thing to point out, which the FDA is addressing and doing a very good, starting to build a team to do a great job at this, is making sure that manufacturers with AI and machine learning are looking at the intended population as they're doing their clinical validations. And I think we have a lot to learn there. I think we'll learn real time from some of that and learn how to improve it, but I think we're on the right path.
Let's hope so. We certainly need it, and need it as quickly as possible. And if you two feel like we're on the right path, I feel like we must be on the right path. So really appreciate both of your times today. And again, thank you, Judy, and thank you, Holly.
Thank you so much.
And so we have gone from the lab side of the ecosystem to the life science side of the ecosystem, along the lines of clinical trials and certainly data standards, in covering these important issues. A lot of the nuanced issues that you don't read about every day in how to drive access and equity in healthcare, in tackling everything from the remote to the absolute core of these issues. And so we have now with us to talk about it to the health plan side. Again, another perspective for you all, the HitLab community, the Columbia Business School community. Another perspective here in understanding this is the health plan perspective around what is driving equity and access through value-based care. And one of the national experts in this area is Nora Dennis from North Carolina Blue Cross Blue Shield. Hi, Nora, how are you? And I think Nora's just signing in and getting online.
Hi there. Sorry about that. I am doing quite well. How are you?
I am good. I'm good. So for folks that don't know you, and for folks who are not familiar with your background, if you could just give a 1 minute or so background on your personal journey into the world of North Carolina Blue Cross Blue Shield and certainly value-based care.
Absolutely. So I am a physician. I am a psychiatrist and also board certified in addiction medicine, and spent quite a while working in clinical medicine and loving it and loving my patients, and at the same time feeling a sense of frustration about all of the factors that were impacting people's lives and their ability to get well, and how many of those we really weren't able to address. And so I think that really led me to want to move into the payer space and want to move into working for an insurance company that was really committed to investigating and understanding how we could do a better job of improving healthcare in order to really move the needle on equity, on behavioral health, on overall thriving for our members. And so I've been at Blue Cross for a little over 1.5 years now.
Okay, that's interesting. And I think that does help people understand a little bit about your journey and how you got to where you are today. And again, as the lead medical director in the area of behavioral health and health equity at Blue Cross Blue Shield of North Carolina, I think the audience would love to hear more about that role and about how some of those efforts that you've led are impacting equity and access in North Carolina and those member populations there.
Absolutely. I think that one of the things that feels so important to emphasize for me is that we have to build out structural components in our organizations to really prioritize equity in everything we do and to have solid governance of those efforts. So while we have these programmatic focuses on our race, ethnicity, language data collection, on our maternity equity, and on our behavioral health equity, for me, it really starts with organizational listening and a commitment to really hearing the voices of the people who are going to be impacted by the work that you do. And so for us in maternal health, that meant starting with focus groups from Black birthing people in North Carolina and understanding their lived experiences, and then also disseminating those learnings to other payers. And so we had women telling us their experiences of feeling incredibly marginalized and unheard in their birthing journey, that they felt so unsafe that they really equated their experience of going into the hospital as being equivalent to that of a Black man who was stopped in traffic and interacting with law enforcement, and that they had a real need to find a healthcare provider who would work with them without bias, and that it was a lot of work to do that. And so people were delaying initiating prenatal care not necessarily because they were busy, but because the actual work that they had to do to initiate prenatal care and feel safe was more work. And so then our strategy has to stem forth from those learnings. And we also have to continue to have oversight of our work by a really committed group of Black mothers within Blue Cross who look at what we do and make sure that it's aligning strategically. And so we're starting that outreach work, we're starting that health coaching work, but it takes longer to start if we want to make sure that we're listening and orienting towards the needs of the communities that we're trying to support.
That's brilliant. That is really so important. And what can the health plan and the hospital communities do to help enhance this, to help really make this a bigger priority on a day-to-day basis?
I think payers have tremendous power to bring focus to equity as a critical component of quality. And I'm sure a lot of folks here read this JAMA paper back in January from Shantanu Nundy, and he said, quality improvement without equity is a hollow victory. Quality improvement efforts without a focus on disparity reduction may have limited effects on health disparities and in fact unintentionally worsen them. So I sort of read that and thought to myself, who actually has the power to look at the data and make sure that doesn't happen? And who has the power to tie equitable outcomes to reimbursement and make it just part of how we provide healthcare? And undoubtedly, the payers are the ones with that power. And I would say even with that responsibility. And if we have clarity around our potential and clarity around our responsibility, then it becomes quite incumbent upon us to really do that work as payers.
That's right. Without a doubt, that is absolutely critical. And it has to be thought about. And it has to be intentional. It's not something that happens necessarily organically, and it really is critical there. And I think one of the things that has been taking the healthcare system by storm over the last 20 years has been value-based care. And we're seeing this being adopted by more and more healthcare systems and health plans around the country. Are you seeing that as something that's helping promote equity and access, or is that actually distracting us from the core issue of equity and access?
Oh, I think we can definitely use value-based care and should be using value-based care as one of the tools in the toolbox to drive health equity, because what it to me is about is combining our priorities and our patients' needs and really contractualizing that to drive action and have payment models that truly support clinical excellence for all. And so for us, we have a focus on provider readiness in our value-based care agreements, but that extends to equity. And so if we take a focus on readiness and we have an equity perspective around that, then what we can do is have a functional glide path to accountability for equitable outcomes within an attributed population for an ACO. So in order to do that, the building blocks, right, we need to have reliable reporting on inequities. So we need to have solid data and agreement about that data with our provider partners. And then we have to have reporting for them on clinical performance and support for addressing those inequities with a glide path to upside opportunities for closing equity gaps. And I think when we frame it in that way, there's really unmitigated enthusiasm from providers about the ability to link equity to their quality performance in the context of value-based payment, because they want to do this work. And a lot of them are investing in this work within their own health systems. And this gives them a way to really support those programmatic and personnel investments in equitable outcomes. And I think that is where the sort of really sweet spot is for us.
That's fantastic. Any parting comments before we say goodbye?
I just thank you for having me here today. I feel like I could talk about this stuff all day. It's such an inspiration to just try to really take this from sort of concept to implementation and actually see change happening.
Yeah, and I think that is giving us hope as we see digital and in some areas getting widened further through access and equity, and this is hopefully an area where digital is actually closing the gap in equity and access. Thank you.
Thank you.
Just a terrific presentation from Nora. Thank you, Nora, for joining us. And we have just a number of different programs around improving access and equity. One of them is at the Columbia Business School Digital Health Program, where one of the cornerstones of the digital health introduction to digital health and digital strategy is around the access and equity components, and certainly making sure that diversity and inclusion is included in that. So again, today only we have, and they've dropped the information in the chat box for you to sign up for the program for today only at a significantly 95% discounted rate of $499 for a CBS enrollment certification instead of $5,400. We would love to have you join us and be a part of that program. Again, it's live, it's virtual, it's online. It includes some of Columbia's top professors who are teaching us about some of the biggest techniques being used for digital transformations, as well as some of the leading industry experts, including a half-day session with McKinsey on how to develop your own digital health strategy. So again, if you would like to, if you look at the Zoom chat box now, you'll see a link. And if you go to that link and use that discount code, you should be able to enroll. If not, if you don't have any success, just email me and I will help you get through that process, or link in as well. And we also have Breakthrough One. Again, Judy Keene and many of the other members that you've seen today are part of the HitLab Breakthrough One program. And again, it's a way to help elevate and amplify your brand in the healthcare ecosystem through not only accelerating network and exclusive introductions, but also being able to access industry trends in digital health. And you also get transcripts from programs like these on a regular basis, including the slides that we're using, et cetera. And different people are presenting, and you are able to really expand your knowledge and your presence in digital health through this exciting Breakthrough One program that Jerry Antomato and his team have put together for you. And so you have a number of different options for this. You can go for the $99 per year subscription, or the $499, the $999, or the $1999 for general, professional, executive, or global. And again, if you have any questions about that, do just put your name in the chat box here, and Jerry will follow up with you on the Breakthrough One memberships. And this is an exciting time to be talking about healthcare access and equity, given all of the changes that are occurring, and given this is a chance that we have to truly make a difference as we're seeing the healthcare infrastructure change from analog to digital, from phone and paper to computer-based and swipe screen and voice interaction. And so that's very exciting for everyone, I certainly know in this audience. And we want to make sure you can continue to talk about this after the symposium today. So we have, again, another Zoom link that has been dropped into the chat box in your session. Take a look at that and join us afterwards for another hour of networking and discussions around equity and access, where it's more of an open discussion and free-form discussion for you to be able to share ideas and learn more ideas about what's actually happening in the ecosystem around the healthcare world here. Now, our last hour is really exciting. We have a whole host of interviews and panels coming up, leading off with Bill Taranto, who is the president of the Merck Global Innovation Fund, and Kelly Benning, who is one of the leaders at Live Metric, which is a breakthrough alliance program run by HitLab and New York City EDC, collaborating together to help bring digital health solutions and those learnings to ecosystem stakeholders all around the world, particularly around the US and the New York metropolitan area. So again, and Bill is a regular here at the HitLab Symposium. Bill, welcome back again. Good to see you.
Good to see you as well, Stan. I'm always happy to be here.
And really appreciate your time, knowing how busy you are in the world of venture capital. So, and Kelly, welcome again. And again, looking forward to hearing this tremendous interview. Thank you, Bill.
All right. Well, welcome everybody. Good morning, good evening, and good afternoon from wherever you're calling in. I'm very fortunate today to be talking to Kelly Benning, who's Vice President of Sales and Marketing for Live Metric. It's my first time meeting Kelly, so I'm looking forward to this interview. Kelly, I'll just ask you to unmute yourself, but you are on mute, and then we'll get started. There you go. Hi, Kelly. How are you today?
I'm excellent. How are you, Bill?
I'm doing wonderful. I'm wonderful. So, Kelly, we have a pretty broad audience, and some people may know you, and some may not. Can you tell a little bit the audience about your journey, how your career got started, and then how you ended up today as Vice President of Sales and Marketing at LiveMetric.
Thanks, Bill. I appreciate the opportunity to share a little bit about myself. My name is Kelly Benning, and as Bill mentioned, I'm the Vice President of Sales and Marketing here at LiveMetric. I'm based out of Denver, Colorado, and have been here for the last 25 years of my career. So not leaving anytime soon. I love it here, but looking forward to all of the work that we're doing globally. And the way that I came to LiveMetric was through pharmaceuticals early on in my career. And Bill, like you, I spent some time at Johnson & Johnson, as well as AstraZeneca. And I'll say this about early on in my career, pharmaceutical companies started, in my purview, patient engagement, or what we know as patient engagement. And why I say that is because as this was happening 25 years ago, they were beginning to advertise to patients on television about their drug. And patients were then coming to the provider asking questions about their disease state and would this pharmaceutical work for them. And at first, physicians really pushed back against this. They wanted to be the expert in the room and they wanted to be the one making the recommendation. But then as we've come to see over the last 10 years, especially, patient engagement is something that providers actually really want and need, because the amount of healthcare that is necessary to provide in the US just goes way beyond what a provider can do on their own. And so was really blessed to start my career in pharmaceuticals and have a better understanding of what was to come in patient engagement. And then spent some time after that working for a physician-led team that did consulting work in orthopedics and cardiac care. And really at that time, gained a great understanding that 100% of physicians want to do better. And that really drove me into looking at what can we provide to the physicians that will help them do better and the patients do better. And that led me to big data sets that are primarily based on machine learning. And so I was able to spend some time at IBM Watson and other companies that really take this to heart. And recently, clearly here at LiveMetric, where we are using machine learning algorithms to help back up the accuracy of our data. And not only that, but using big data sets to really drive healthcare forward, because the problems are so epidemic in nature and so large that without these kinds of data sets, I really don't see healthcare moving forward like it should and as fast as it should. So my passion is here with these companies that are utilizing big data sets and that are necessary to really help move healthcare forward. So.
Great. Well, it's always good to talk to a fellow J&J alumni, but wonderful career progression. You can see you can do a lot of things in healthcare. So I want to talk about LiveMetric first on a broad basis. Then I want to get into next after that, into the exciting news that we just saw posted about your new blood cuff monitor. But first, let's talk about LiveMetric broadly speaking, and what do you all do and how do you help patients, and what differentiates you, do you think, from other types of companies?
Yeah. So just to share with you a little bit, this is the LiveMetric device. It's a wrist-worn wearable and it's non-cuff based. It has 4 MEMS nanosensors in it that are mechanical sensors that measure actual radial artery pressure. So very similar to an arterial line used in the ICU. We are highly correlated to arterial line and provide very accurate blood pressure readings. And why this is important and why this is different than a traditional cuff is because the process behind cuffs is typically that a patient will use their cuff at home. They'll go to the doctor's office. The doctor will take 3 more measurements in office because he's not really sure that those measurements taken at home were accurate. So he wants to verify it in the office. And then they spend time, maybe 6 or 9 months, titrating medication for blood pressure. That's just too long because they don't have enough data and they don't have correct or accurate data from which to base these really important decisions. And so LiveMetric came about because we see this problem and we know that there's major room for improvement. So what we did was create a monitor that can be worn passively, even during sleep, as we know that this is really what drives patient engagement, is when there doesn't have to be a lot of work done in order to receive these types of readings and to receive them in big data sets where you can actually trend over time what's going on with your disease state. We saw this with Dexcom, where patients could have in real time how that continuous data was impacting their lifestyle and behavior and what they were doing. to make that happen. And we hope to revolutionize, and we are going to revolutionize hypertension in the same way. So it's not necessarily something of a small problem, I will say. The WHO organization calls it mankind's largest epidemic. 1 in 2 adults has hypertension, and 75% are uncontrolled. It still leads to the #1 killer of stroke and heart attack. There's probably not anybody on the line today that doesn't know somebody who's had a stroke or heart attack. And so we picked kind of the biggest problem, one of the biggest problems in healthcare, and have devised a way for patients and providers to have access to these big data sets that are going to really make an impact on how they can manage their care for hypertension and cardiovascular disease.
So let's talk about then the device more specifically. How does it actually work? Does the data go directly to the physician and then they intervene, or does it go back to like a call center at LiveMetric? Can you kind of tell the audience a little bit of, if I get that, that wristwatch that is measuring my blood pressure, what do I need to know as a patient, and where does all the data go?
Yeah, this is really important and very key to patient engagement, is knowing that your provider is looking after you, that they're monitoring your data. And so there's new codes for reimbursement, whether it be remote patient monitoring codes or self-monitor blood pressure codes, that are driving physicians to look at the LiveMetric data every month, or even more often than that if you're titrating medication, and being reimbursed for that. And so we have a definitive path into EMR records, as well as the patients able to receive their data on their app on their phone, whether that be an iPhone or Android, where they can download reports, email them, and share them with friends and family. But as you and I know, the way for the patient to best manage their care is to be in coordination with their provider. So the data will go directly to the providers via EMR integration.
Great. And how do you see the evolution of the device? So right now you're measuring hypertension. Is the idea that maybe you move into, whether it's EKG or maybe monitoring AFib, what you see some of the other devices doing, is how is LiveMetric thinking about the evolution of the cuff, the non-cuff device?
Yeah, this is actually a great question, and something we contemplate on a daily basis is what is next, and what does the market need, and how can we best help providers and patients manage their cardiovascular disease. And because LiveMetric utilizes MEMS nanosensors, we collect a very high quality signal at 100 hertz. And because we collect this high quality signal, we actually have a picture of the full pressure waveform. No other device can provide this. And through that full pressure waveform, we're able to see disease states that would normally only be identified through echocardiograms, labs, ECGs. We are currently studying them at Columbia and other organizations, where we're looking at, can we build the machine learning algorithms to see these disease states in the full pressure waveform, and identify those to patients and providers very much prior to the patient having symptoms, or prior to the patient getting an echo or labs done. And so we're currently studying things like biphasic systole that we can identify with the full pressure waveform, or masked asleep hypertension, and other disease states. So that is a large focus of LiveMetric right now. And with our FDA, we are commercializing and working on both the commercialization side of things, and then this further research. And because of this full pressure waveform, it really differentiates us from any other device on the market, because even over 1 heartbeat, a doctor can see the impact of a beta blocker on a patient's hypertension. So we're going to begin to study that in depth as well, is how do we know which medication works best for which patient type, and can they see that in a short period of time? So we're really excited about the future of LiveMetric in terms of what we can see with the full pressure waveform. And then in terms of other sensors, I think that that's definitely a possibility. I know that it's something that the market is asking for. And right now, as we look down the road at our product roadmap, we're contemplating the other types of sensors that we'll be adding to our device.
And do you think those sensors are going to also be risk-based, perhaps, or do they might be different types of sensors you wear on different parts of your body? For example, some of the newer AFib sort of devices, those patches that you see on the chest.
Yep.
or do you think you can measure most everything from the wrist, basis?
Yeah, that is a great question and something that we are doing research on right now because, for example, temperature is one of the more difficult ones. Whether you get a temperature on the wrist or a core temperature is important to the provider and important to the patient. So we're really determining where the best signal is from and how to report those results. And currently we're looking at adding other sensors to our wrist device in an effort to make it easy to wear passively, easy for a patient to put it on night and day and just kind of forget that they're wearing it. There is definitely benefit in patches and other devices, but it just adds to the work that a patient would have to do. So I think our first focus will probably be on how can we add additional sensors to this passive monitor that we currently have.
It's been an interesting evolution as you see these devices sort of changing and grow and how the market changes. If you look at the whole sort of what I would call the digital medical technology or digital device, how do you see that sort of market evolving over time? I mean, I think what you've come up with is very unique and differentiated in the market, but just how do you see this sort of, aside from the therapeutic where you came from, sort of that original business to these types of things that might change the way we think about healthcare?
Yeah, this is something that we've seen explode with COVID, right? We've seen patients who are not showing up to the provider's office to have their annual exams, or they're not showing up when they have symptoms of a disease state because of COVID. And so we have seen and are continuing to see a massive push into the marketplace of patients being able to self-monitor. And that self-monitoring is critical because what we don't want are patients showing up in the emergency department with stroke and heart attack and hypertensive urgency, these types of things, congestive heart failure exacerbations. We want them managed in the home in a much better way so that they can have improved quality of life. And that means monitoring. That means the patient taking an active role in what they're doing. And so I think COVID sped this up, by 10 or 15 years, I would think, in my opinion, about what we've seen changed. And I don't think it's going to go backwards. I think it's going to continue to go forward. I think patients really like the idea of being able to co-manage their condition alongside their provider. And we're continuing to see reimbursement codes that mimic this as well, where they want those patients monitoring at home so that they can help improve their quality of life. And we're seeing physicians adopt it. We're seeing third-party companies come in and adopt these kinds of remote patient monitoring. And it's all based on digital health tools. And so the key component for digital health is really patient and user satisfaction and engagement to keep them monitoring. And so that's always top of mind. And that's the way digital health is going to grow, is can we keep the patients engaged and the users engaged? And I think that needs to be top of mind for every digital health company as we continue to push into the marketplace to better outcomes. So that's our goal for sure.
I agree. Okay, we have a couple minutes left. And I always like to ask, since I'm chair of the Breakthrough Alliance and I'm a proud member of the HitLab community. Yeah. Your involvement, you're kind of interesting, your involvement with HitLab, because you're one of the, I think, the companies that went through their process. Can you tell about your relationship with HitLab and how they've helped you in your journey?
Absolutely. We are thrilled to be a Breakthrough Alliance winner through HitLab and honored that they bestowed that upon us, because we've been able to use the HitLab resources and people at HitLab to spread the word about LiveMetric and really have some more influence within their ecosystem, which the HitLab ecosystem is massive. They have everywhere from investors to healthcare enterprise to help build an audience for your development of your product and to engage that community. And so we've had several opportunities like this where we're able to engage in those communities and then use the recordings of these to further engage other stakeholders, whether it be through email or on social media channels. And in addition to that, we're very excited because we're going to begin some research with HitLab, where you might know it as real world data, where we put the band on users with hypertension and begin to see how do they use it with the hospital, or how do they use it with a payer system, and what does that look like? And so we're very excited to use their knowledge and expertise in this area of digital health to help us coordinate and put together this type of research study. So we're really excited about that aspect of it as well. And just couldn't be more pleased with the service and the expertise and influence that we've received as a Breakthrough Alliance member of HitLab.
Well, wonderful, and I'm glad you got the opportunity to work with HitLab. So that concludes, Kelly, our discussion. The 15 minutes always goes way too fast. I see Stan has come back on, but I want to thank Kelly for joining me today. And I'll probably be back next month interviewing again someone new. So I'll see the HitLab community again next month. Stan?
Thanks, Bill.
It's absolutely fantastic. Wonderful interview, Bill. Thank you.
Welcome.
And, again, we're really hearing about the Breakthrough Alliance now and all of the work that's been going on over the last really 6 years since it was founded with New York City EDC and HitLab and just tremendous technology, again, live metric just approved by the FDA for real-time blood pressure measurement, and incredible product that it is. We're looking forward to seeing and hearing great things coming from what they've done over the next several years as well. And, when we talk about diversity, and we talk about equity, and we talk about access, one of the cornerstones of that is around inclusivity. And our partners over at Dime have created a toolkit for inclusivity. And we're very lucky to have Jean Chung, who is extremely busy, one of the busiest people we know, who leads up the strategic program unit at Dime. And we'll be talking a little bit about the actual toolkit itself and how important it is to be able to have this kind of element when talking about equity and access. And again, it's just one of the baseline features that people are looking at when they do this. And again, Jean, welcome to the program. Where are you and how are you?
Hi, so excited to be here. I'm in New York City.
Fantastic. All right. Well, good to see you back in New York City. And again, looking forward to hearing about what the toolkit does and how how folks can use it or elements of it to help them improve inclusion and certainly equity and access.
Yeah, absolutely. Really excited to just dive right in. I'm going to start sharing my screen. So I do that, I'll say, so I'm Jean Chung, Stan introduced me. I'm a strategic program lead at Digital Medicine Society. And I'm going to talk to you about the body of work that I had great privilege of working on, hold on a sec, in the past few months on the digital health measurement collaborative community. And we've launched 2 toolkits around the deployment and development of digital health measurement products. And just stepping back and saying, like, we all know why you should do this work. We sometimes don't know how. And so how do we move from like this big, compelling reason for doing good and making change? And how do we operationalize? So that's why I love using this tagline from should do to how to. And so today I will go through first a lead up and then to the good stuff, which I'll give you quick demos of the toolkits themselves. So we're all familiar with the information on the slide, particularly the last slide, right? We have the opportunity in digital medicine, at the crossroads of technology and healthcare, to not only ameliorate existing biases, but to build the future of healthcare that we all know is possible. And so DataCC, it's the nickname for a very long name, Digital Health Measurement Collaborative Community. It is a pre-competitive collaboration focused on digital health measurement specifically and what we can do to move the needle on that within the healthcare ecosystem. Very quickly, the collaborative communities are a strategic initiative of FDA CDRH, and they had asked us, Digital Medicine Society, to host DataCC. So Dime is the proud host of DataCC, and that's how I'm involved with the work. Me and the program director, Yashoda Sharma. She should be listening in the audience today. I can't see if she's here or not right now. She and I were guiding this work that resulted in the toolkits. Very quickly, Digital Medicine Society is a nonprofit. You can read kind of our mission statement there, but it's all about collecting or gathering the innovators, the forward thinkers, the cross-section of healthcare and technology to optimize human health. So DataCC, right now it's 46 member orgs, and you can see from the logo cloud that we've got kind of anyone and everyone from every dimension of the healthcare ecosystem. DataCC's mission is around digital health measurement. And we kicked this off last year, and they decided in this diverse group to focus on inclusivity. It all coalesced on this big challenge they're seeing from so many different areas. From there, we quickly understood, right, that there are nuances and there are different needs based on if you're designing and developing a product and if you're deploying a product. We also, the steering committee also spent time delineating, right, the key vectors of inclusivity, which are threaded through the rest of the work. And so just step back really quickly about DataCC. DataCC is oriented around digital health measurement and the challenges it faces as we continue to innovate and push for this new future. It's not only around inclusivity, but their first choice is inclusivity. So let's dig in. So this is what we launched at the end of May, 2 toolkits. And I won't go through I won't read you the slide, but I'm going to take you through demos. So on the toolkit for development, right, we understand the big why we need to do this. We've created this thing called the Opportunity Model Calculator. And it helps us with the other why, the commercialization, building the business case, to size the market and value the market for our potential digital health measurement product innovation. The other thing we realized very early in this work, again, anchoring in that idea of like should do. There are 10,000 blog articles around be more inclusive, think about diversity, but not a lot of action and also not a lot of numbers. So we created here was a library of evidence that has over 100 resources that have actual numbers, percentages around risk reduction, percentages around customer engagement, stats on being able to improve representation in clinical trial populations, all of that in one place. It's pretty powerful. And then finally, the how, which is our framework. And it's a step-by-step guide for considerations along dimensions of inclusivity at every step of your product development process. So that's the development side. On the deployment, right? So deployment is very different. The tool already exists. We're deploying it in likely 2 different contexts of use, right? In a clinical trial or in the delivery of care. And what do we need to think about? And so we oriented workbooks and guides to help people really operationalize, understand what they need to do, get closer to making decisions, and getting closer to supporting the end user in the way that is the best for everyone. So from there, I'm going to jump into the demo. So here we go, DataCC. You can see the URL here, the home page. When you drop over to the development page, see the 4 items I mentioned here are listed here, and then we have them here. What I'm going to demo for you is the Market Opportunity Calculator. It's something we're really proud of, and it's really innovative for our industry and very cool. So we've got major health conditions. I'm going to choose diabetes, and major inclusion vectors. Here, I'll choose race and ethnicity. On page 1, what it does, it shows you the strata of US population. It shows you the health condition distribution across those inclusivity vectors. And then over here, which is I think the cool part, because it's easy to understand super fast, where's the kind of the disease burden and therefore also the opportunity for us to pursue. That shows the over-indexing of this particular health condition for this particular segment. So we can see we can innovate for here for outsized impact. Next is the fun part. So here I like to think of it, if I'm a designer or a developer and I'm very oriented and motivated for huge improvements in my new product. Let's say my current product is getting about 30% engagement. Here, what I can play with is say, okay, for all of those over-indexed populations, I'm going for over 80% engagement on my tool. I'm going to design it so well that it's going to be sticky, it's going to be phenomenal. What this part of the calculator does, it shows you the size of population. If I can move these segments from 30 to over 80, these are the potential people we could reach. Next is the money. So let's say my new product I'm going to sell for $99. What this does is say, at my current level at 30% engagement at $99, what is the value of that? Here it's about $800 million. And now with my great improvements, all these innovations around engagement, at this level, it's now a $1.7 billion opportunity, which if you don't want to do the math in your head, it also shows you the delta. The next page is the results that you can download and as a PDF. But the idea here is that it is real time, it's live, you can move all of these around and you'll get the population numbers as well as the value. So that's the market calculator. I encourage you absolutely to play with it. It's very fun. We developed it with DataCC and DIME and Harvard Business School. The library evidence is very straightforward. You kind of flip through different categories. Every resource is linked and categorized on different benefits and different aspects of inclusion. So I mentioned the process. We delineated, I think for the first time, a digital health measurement product development process. We leveraged the FDA development process and beefed it up a little bit. In this particular representation, we also provide definitions, like what happens at each stage. Understanding, of course, that this process is never linear and it's unique for every organization. We tried to get to a level of uniformity that would be helpful for everyone. And finally, we've got the framework. So I think the model is cool, but I think the framework is also equally cool. So leveraging the process, this document is a page for every step of the process. Each page gives you specific common problems at that stage regarding inclusivity, some of the risks, then it breaks down to subpoints and considerations you should take. So this is not rocket science, but it's meant for you to anchor into inclusive considerations as you're developing. Here's an example. So we have early user testing. You identify, design, invite, conduct, follow-up, okay, basic steps. For example, in invite, this orange box is about considerations that you need to take. Language, health literacy levels, tech literacy levels. What do I need to consider when I invite people? And when people show up or when we want them to show up, have I thought about things like transportation, childcare, taking time off from work? Should they be compensated and at what level? So having that all in one place is really the purpose of this tool. We also have linked here relevant resources all at your fingertips. So that's the development side. That's the development toolkit for main components. Next is the deployment. So deployment we oriented a little bit differently, as you can understand, like it's just a different animal. The product is already in use, it exists, and we're trying to get it out into the end user's hands for a successful use. So we oriented this toolkit in a different way. We have tools oriented around patients, participants, communities, when we're ready to implement, and then again, a resource library with all the relevant resources in one place so you don't have to get lost in your Google search results or in your 3,000 bookmarks if your bookmarks look anything like mine. So here, the way we've oriented the page is, it's a question. How do I plan for effective community engagement? What should I think about? So here we have guides that you can read through and they're downloadable. Here is a very cool tool in a workbook format. In this workbook, so oriented around prepping end users, we have things like a sample end user agreement, FAQs for end user, for privacy security, questions to ask. This particular one is a tool that you would give to a user so they know what to ask, so they feel comfortable and ready to use the product. And I'll mention two things here. One, in the workbook, you can download each of these templates, and that's available to you. And also, this is meant to be a starting point. We understand the tools are going to ultimately be fit for purpose for your specific context, for your specific population, and for your specific tech product. But this is meant to give you an idea of what to consider. Then we have when you're implementing inclusive deployment workbook, similar construct. We have a bunch of tools for you. Same thing, you can download, use them, modify them. One thing I really wanted to highlight is this. This tool I love, I really dig, because we think about inclusive communications and you think it's pretty inherent. Like, I think I know what I'm doing. My language is pretty inclusive. This tool has a written description and 2 other versions, and it gives you readability scores. How readable, and you can see the first one's not so readable, and you move down. And it's a very concrete example of like making assumptions or being able to understand how you can improve your work. And then on the other cool thing in the toolkit is this other workbook. We've created a flow chart for you to understand. Once the tool is in the hands of the user, their questions, how do we support them? Introducing ideas like a digital health navigator. How do you support people in these experiences and these medical and health needs?
That's fantastic. Well, Jean, this is great, and we really appreciate your time today. And again, we'll drop your LinkedIn into the chat box. For anyone who has any questions for Jean, please follow up on LinkedIn. And again, tremendous presentation. Thank you.
Yeah, thank you so much.
And so we go from toolkits around being able to drive access and equity through this ability around inclusion and making sure that everyone is on the same page when it comes around to not just talking the talk, but actually walking the walk with inclusion, to adherence and medication adherence in clinical trials. Because when we think about access and we think about equity in healthcare, a big part of that equation is around the ability to make sure that not only are we seeing the clinical trials being done in a way that is equitable for and across the ecosystem, but we're also seeing clinical trials and data being gathered in a symmetrical way. One of the biggest harms in pharmacoeconomics right now, and certainly pharmacovigilance, is around the equity of and the symmetry of data collected. And if you have a study of a pill, of a molecule, and the data is actually not really managing clinical trial participant usage of that pill. So effectively, a lot of clinical trials, as we saw in the Pittsburgh study in 2000, going back 22 years now, 30% of clinical trial participants just don't take the pill, 30% report taking it before they ever take it, and then 30% take it when they're actually taking it. And so one of the issues that causes is a lack of trust in medications in general, because by the time the real effects hit a population post FDA approval, it's 5 years down the road, and now we're seeing massive implications on the molecule and its effect on the human body. And we're only then beginning to understand, because the clinical trial data was not accurate. Addressing that is one of the world's foremost leaders in clinical trial adherence technologies, Joanne Waters, and talking with her is Greg Bauer, who heads up partnerships and alliances at HitLab and is also a senior innovation fellow. Greg, thank you for joining us today. Joanne, thank you for joining us today. Greg, you are on mute, and I'm going to hand the virtual video camera and microphone over to Greg.
Okay. Thank you, Stan, and thanks, Joanne, for joining us today. I'm delighted that we can have this conversation. I know that, Joanne, you've been involved in these clinical trials and remote monitoring of participants in these trials for many years. Maybe before we get into our key discussion, can you maybe just tell everybody a little bit about IMC and the ServScan platform that you're working with?
Yeah, sure. Hi, Greg. So you can hear me fine? I'm not speaking too loud?
We're good.
Okay, awesome. Thanks very much for the introduction, Stan, as well, into the medication adherence field in the world that we live in today. IMC is Information Mediary Corporation, and IMC has been the leader in understanding how patients take medication and tracking adherence for well over 2 decades. I have been blessed to have been part of that journey and have been working with IMC and many researchers across the globe for the last 17 years. As Greg had mentioned, we like to remain and think that we are forward thinkers when it comes to understanding technology and the digital pathway that we see coming through understanding how patients take medication. That involves a Certiscan platform, which actually is an adherence platform that helps researchers and research teams understand actually how people really do take medication. Certiscan is a platform that offers very powerful visualizations for research teams to understand the patterns of dosing and provides researchers actionable insights to help patients get on track to taking medication as prescribed.
Yeah, that's great. And so given that, I think you're going to be able to help us a great deal in some of what I'm kind of focusing in on. It turns out that the FDA released a new set of guidelines or guidance for clinical trials in April this year. It was called the Diversity Plans for Improving Enrollment of Participants from Underrepresented Racial and Ethnic Populations in Clinical Trial Governance or Guidance for the industry. And so this guidance seeks to increase the number of racial and ethnic participants that have historically been underrepresented in clinical trials. And so the agency says its focus is really on on having a broader spectrum of Americans enrolled in trials, and it aligns with the Biden administration's goals of addressing inequities in healthcare. So when I look at that, I think about the FDA just having raised the bar for administering a clinical trial. A sponsor must not only meet its statistical endpoints and do so cost effectively and on time, but it now must accomplish this while recruiting a more diverse participant base, many of which may be very difficult to find, especially for the larger phase 3 trials. So this begs the question how a sponsor or a CRO manages participation or participant adherence, which of course, as you laid out and as Stan talked about, is ensuring that the costs don't go up and it reaches their points. So Joanne, first question I would have for you is, what are some of the specific challenges that a CRO would face in monitoring participants of a clinical trial, just as a baseline of discussion?
Well, that's quite a directive that the FDA is putting out. So it's nice to see that they're, forever trying to improve clinical trials and patient health outcomes. So that's a very key directive. So what happens is this, especially, US clinical trial teams always try to get the most diverse population with inclusion and exclusion criteria. And what we've seen over the past several years, and we have many studies that have done this, is you have these hybrid models basically that think of the patient engagement remotely and how better to serve those diversified and underserved populations. So they're really quite clever in doing ways where you can actually have technologies such as remote monitoring of medication, intelligent packaging, those sorts of products that are in the hands of patients. Currently, a lot of them will get mailed out or delivered by courier. So there's some sort of traceability level on that to get the patient the medicine that they do need. So with technology, what's happening is you can have medication packaging that actually can track each time a patient removes a pill. That data can be transcribed and pushed to a cloud through many different ways. But if you're serving underprivileged and underserved populations, you can actually have a hybrid where a care team can meet possibly halfway rather than a patient having to drive 3 hours or take a bus that might take them 5 hours to get to a clinic site. So it's basically extending the reach using digital health tools and also allowing mobility of product that can actually track real-time medication usage, which is what you're trying to do. You want to make sure the patient can take medicine, and you want to make sure they take it as prescribed, right? So if you can do that remotely, you can actually reach an entire category of underserved and underprivileged populations. And I think that's a big key with digital health and remote monitoring is you can extend what the FDA's directive is to serving the outreach that they need to help with the clinical trial results.
You raise an interesting point there also, Joanne, about traceability of the dose. I mean, part of the trial and some of the people in the trial, their responsibility is to make sure that down to the actual pill, they have clarity on where that pill went and where it was consumed, yes or no. I'm assuming that something like this remote monitoring would greatly ease the burden on someone who's trying to manage the logistics and the supply chain of the trial.
Oh, absolutely. I mean, especially when you bring in the clinical research organization who are the direct contact with the patient, right? So you mentioned the cost of jumping from a phase 2 for a phase 3, which is a huge population increase, right? And each patient increased is a very dramatic cost to a clinical trial, right? So what'll happen is this. If you can actually keep an eye on your patients where they're engaged, and it's not a broad stroke approach where you are tracking patients like where there's beams coming from everywhere and this and that. It's a very simple experience where these intelligent packaging formats and solutions are really non-invasive to a patient. They just take pills as they normally would. There's nothing different, except there is a traceability step in there, which is critical to supply chain and also critical to having the CRO know that the patient is actually, hey, I'm really, you're doing really well. You're taking your pills as you should. And that broad stroke approach will see and point out that, as an example, an actionable insight, if a patient is dropping off their persistence of the treatment, a CRO can reach out at that point and say, what's going on? We want to keep you in the trial. Are you feeling okay? We see that, your medication is dropping down. How can we help you? So it obviously provides a nice tighter relationship between a CRO and a patient. And then patients feel empowered because they're like, oh my heavens, somebody actually cares. And I want to continue with the trial. And especially with underserved communities, there may be language barriers, there may be all sorts of potential obstacles that keep them from not wanting to go into a clinical trial. So if you can actually say, we're going to help you and kind of handhold you, I think that's a great step forward.
That's a really interesting point because what you're raising is the concept of it's a team-based approach. It's and especially with trying to get to people who are more difficult to reach, it's got to be a collaborative effort between the sponsor, the CRO, even maybe the CMO, the manufacturing folks who are trying to get their distribution out to the patients. And the whole even patient education, patient literacy, engagement, all of that has to happen in order for the patient to adhere, I would imagine.
Yeah. So one very important thing that our data shows over these decades, obviously we have a lot of fantastic data. We had what we see, the longer the treatment, as an example, in a 6-month 4 studies, we saw that the adherence rate dropped off quite significantly. And these are important things because what happens is when the persistence levels start to drop, patients aren't doing what they are supposed to per protocol. They don't necessarily feel well. So you're going to possibly lose those patients. And again, it comes back to enrollment and trying to maintain that enrollment number. We do see as well, if you can actually, adherence rates it is proven, and there's literature that shows self-report is typically, and recall bias is a little higher than, as an example, an intelligent electronic solution of packaging. So what'll happen is if we could even increase adherence by 1%, which is really, not a lot to deal with, we could actually reduce the population size by 2% and still provide statistical significance. So if we could do that, when you jump from a phase 2 to phase 3, and the FDA directive is to try to keep that population as diverse as possible, the lesser the population numbers might be easier to get in that diversified, population group. So there's lots of ways that remote monitoring and smart packaging can actually help the sponsor, but as well as the patient health outcome, and basically follow these directives the FDA is putting out.
That's great. You know, it's funny, as you were talking, we just got a comment about financial incentives aligned from one of our viewers. And I was going to ask you as my last kind of question before we turn it over to Stan is there a rule of thumb that says if you can, like you just said, 1% may reduce the overall cost by X amount to get your endpoints? Is there, especially in the area of trying to get participants engaged, is there a cost factor, like a ratio or a rule of thumb that people can look at around how remote monitoring can improve cost and effectiveness at all?
Well, I think the whole point of that is it's an enormous ROI through many different levels, right? So obviously the ROI can be per patient. You spend $40,000-$50,000 on one patient. If you can reduce that size, jumping from a phase 2 for a phase 3, there's some numbers right there to throw. But also the important part is perhaps abandonment of a drug. When you actually, in your phase 2, you see this real-time, real-world data and you think, oh my heavens, this is really not, we have to change something. The molecule's not being as we had intended. And then so you have those cost savings as well on the R&D side. But
That's a
again,
good point.
getting your drug to market faster with such evidence-based data will actually get your data hopefully to the FDA and approved much quicker. So you have a longer patent use life on that as well, right? But again, it's about patient safety and dose optimization and all those good things about medication adherence.
That's great. Those are some really terrific points, Joanne. Thank you for joining us and for making that the clarity of some of those points. Stan, I think I turn it back over to you.
That is correct, sir. Thank you, Joanne. Thank you, Greg. Great session on medication adherence and health equity. Thank you both.
Take care.
Just a lot of insights there. I mean, it really is amazing to listen to someone like Joanne Waters, who has been in the ecosystem now for a few decades and has really been one of the folks who has built the digital health ecosystem and the smart, this kind of medication adherence solution that goes beyond just the packaging and goes into the IT solutions, and truly one of the leaders around the world in that area. So we have next up just another exciting book giveaway to do. And so get your keyboards ready and answer this question. First one to answer gets the last but not least personalized book from Mr. Donato Tramuto. According to the Markets Insider, by 2025, the global electronic health records market is expected to reach what size in US dollars? Of course, A, 20 billion, B, 33 billion, or C, 49 billion, or D, 1 trillion. We've got answers all over the place. The correct answer is B, $33.4 billion. And a lot of people did answer B. But the first one who looks like they answered B, going back up here, was, looks like, I don't want to say that yet. All right, James from Canada, our venture capitalist extraordinaire, and a CBS Digital Health Program alum. Well done, James. Good to see you representing the Columbia Business School Club. So anyway, James, look for your personalized signed copy from Donato Tramuto, who just so happens is our next and our last keynote speaker here today. And he will be talking about the double bottom line. And I have to say, I've known Donato for 3 decades, and his work is really thoughtful, very intentional, and will provide insights to anybody, whether they're a 22-year-old just getting out and started in the healthcare ecosystem, or someone who's been around healthcare for decades. This kind of compassionate leadership, this kind of understanding how to lead with empathy. And so really trying to put yourself in the other person's shoe, whether it's you're a startup and you're trying to make a pitch to a venture capitalist, really trying to envision what that venture capitalist is looking for, or whether you are a life science company and you're working with a startup trying to envision what that startup is going through. And so you can build better partnerships, build better relationships when you start taking that compassionate leadership perspective. And there is no one who can talk better about that in the world than Donato Tramuto. Donato, welcome back to the program. Always good to see you. Assuming you're in Algonquin, how are you doing?
Sorry about that. I was muted. Stan, thank you very much. I'm doing fantastic, and it's always really great to be involved in anything you do because you do it from your heart with great intellectual focus. So thank you for inviting me today.
No, I really appreciate it. And again, a lot of our audience knows who you are and knows about your work, albeit whether it was running a NASDAQ 1000 company or whether it was running Physicians Interactive or other companies before that. But give people like a minute or so background on your journey.
Well, thank you very much. I've been in healthcare now for 4 decades, but I have been focused on being a compassionate leader my entire life. I am reminded by the great quote from Mark Twain, the 2 most important days in your life are the day you are born and the day you find out why. And Stan, I think you have articulated it very correctly. For me, it's never been about, just business. It's been about integrating the business imperatives with people first. And my latest project is really helping to make the world a little bit more compassionate and kind. I have been fortunate. I'm a product of having lost my hearing at age 8, as you know, and for 10 years, I had little to no hearing. I think that experience, coupled with the tragedy of 9/11, as you know, I was supposed to be on that second plane that hit the South Tower, and my 2 friends and their 3-year-old who were staying with me that weekend boarded that plane. But I think those 2 situations discovered not only my professional why, which was healthcare, because I experienced a lot of medication errors and mistakes during the time that I was struggling to get my hearing restored. And then, of course, 9/11 really established my personal why. For the last 20 years, I have been dedicated to making the world a more just and fair place. The last 2 years, by design, I stepped down from being a CEO. I had been putting that into play for a number of years to dedicate whatever time I have left to this notion that we can lead with the focus on profits and on people. It doesn't have to be a trade-off. And so I am really touched by how the book has taken off. It's been a bestseller on Amazon in several categories for the last 4 months. We're now going into our second reprint. But what really makes me feel tremendously satisfied is just the number of leaders who have reached out to me and said, you know what, you're absolutely correct. I have an opportunity now in this new abnormal sense of the work environment to define a whole new leadership standard.
That's fantastic. And if you could, Donato, tell the audience where the title, the double bottom line comes from.
Well, that's a very good point. You'll get a kick out of this, Stan, because you've known me for years. My publisher put 50 different titles in front of me, and I turned everyone down. I wanted it to be the double bottom line because for many, many years, when I would establish my leadership mantra as compassionate, many of my colleagues would say, oh, that's weak. You have to be focused on profits. And I would look at them and say, well, I am. I didn't get to where I'm at today by not being successful. And I am also focused on people. And so it's really an establishment that you can deliver results and captivate hearts. Now, whoever knew during the time that I had established this book as a project that we would be faced with one of the toughest work environments that I think we have observed in our lifetime. People call it the Great Resignation, Stan. No, that's the wrong term. It's the Great Reflection. People are reflecting on their lives. The resignation is a consequence of that. People are reflecting on their lives like they have never done before. There are 5 generations now in the workforce. And so we have to really understand that we can't just lead in this hierarchical manner. And so the double bottom line is a recognition that we are not suggesting you forget about profits. In fact, you have to be profitable or you will not remain in your position, but you can be impactful by also putting people at the top.
That is spot on. And we've got some interesting comments too, Donato. Someone actually in the audience went through 7 years without their hearing and is definitely empathizing with what you've gone through. And so you, in building this book and really completing this project, you interviewed dozens of some of the world leaders, some of the biggest business leaders, not-for-profit leaders, government leaders out there. And it'd be great, just as a synopsis of those and a synopsis of the book, what were some of the most interesting things, some of the biggest takeaways that you came away with in talking to all those folks?
Well, Stan, you may not know this, but you have had a great influence on me. You taught me a lot about the importance of data. And I have to be honest with you, when I was contemplating the book, I was only thinking about interviewing 10. We interviewed 41 world leaders, and the audience will know some of them. We interviewed Bruce Broussard, the CEO of Humana. We interviewed Katie Couric, Alex Gorski from J&J, but I also interviewed a 17-year-old young lad who during the pandemic started a company that was focused on helping seniors learn about how to use social media. He wanted to pull them out of their loneliness. And so this is not a book according to Donato. This is a book of deep research. And we went one step further, is that we surveyed 1,500 people in the United States. And we really extracted some really important nuggets. For example, we saw that 84% of respondents believe a compassionate workplace leads to cooperation, which in turn leads to greater productivity and profitability. Yet most workers, 68%, believe that the workplace is more competitive than cooperative. And so we really drilled down with the 41 leaders that we interviewed, and they agreed that for whatever reason, the competition should be outside the four walls of a company. It shouldn't be inside. And if it is inside, you're not going to get the cooperation. And cooperation is one of the key nuggets in terms of how you can lead with compassion. The other thing we learned, we came up with the definition of compassionate leadership. I didn't go into this project with a definition. Compassionate leadership is empathy in action. It's not just good enough to say, I feel the pain of that person. Stan, every issue that we are trying to address in healthcare, whether it be loneliness, whether it be healthcare access, whether it be food insecurity, if you don't understand the pain of that other person, you will never come up with the kind of solutions that can really be delivered at scale. Because I lost my hearing, because I had 8 years of bullying and I was in a state of loneliness, because my sister-in-law died in childbirth as a result of medication error, rest assured, I know the pain of someone who tells me that they're lonely. I know the pain that when someone tells me I lost my hearing because of a medication error. And so I have devoted my professional career to try to address those issues. And so for whoever is listening here, every leader that we interviewed, they were not born with compassion. They learned it. They either learned it, some, learned it from their parents in their homes when they saw their parents struggling. Some people learned it during COVID. Other people learned it in a situation that they got involved with one of the employees and they realized, you know what? It's okay to be vulnerable. And that is another key element that we extracted out of the data. If you're not vulnerable, then you're not going to really make connection. Stan, for many, many years, I hid from my employees that I was deaf and that I had a speech impediment. I still have a speech impediment today. There are certain words that I can't pronounce, and that I'm a gay man. And when I received the 2014 Ripple of Hope, the Robert F. Kennedy Ripple of Hope Award, alongside Hillary Clinton, after her speech, I was getting up to present my speech, and I was not going to mention my partner. I was not going to mention my hearing loss. I was not going to mention that I failed the 5th grade. And I said to myself, how can I possibly receive a human rights award and not be vulnerable. And you know what? That night, in front of 400 of my employees, over 2,000 people in the audience, I shared my story. And I got a standing ovation. But what was more really moving to me is that afterwards, the employees came up to me, and it's kind of funny. They said, "Thank you for sharing that. Your life now is more interesting. We thought you were boring." And so we have to be willing to share our stories. And that's what I really found in all of the interviews. My last point, we rent our titles. We own our dignity. And dignity is about being who you are. And if you're not willing as a leader to be vulnerable and to share your story, you will never connect to the stories of other people. And that is what we write about in this book. And it's what I really do believe is going to help our leaders.
Brilliant. Absolutely fantastic. Donato, thank you very much. And on behalf of the audience, and certainly everyone at HitLab, thank you for joining us today.
It's good. Stan, may I just sign off with this last point?
Please. Yeah.
We just learned this past week that we have received the National Compassionate Leadership Week. It will now be on the calendar. It will be on the calendar for September 11th to September 18th in perpetuity. And so for all of you who are listening, this is your opportunity to join the movement, not just to read the book, but to join the movement. And we couldn't be more thrilled that this calendar classification has been now given to us. And so we all have an opportunity to show empathy in action. Thank you very much for having me here today.
That's wonderful. Thank you, Donato. Wonderful presentation and just an incredible book. I would definitely recommend everybody grab this copy. It's a life changer, without a doubt. It really is. And his experience as an executive for 4 decades and then really supplemented with the interviews that he did was fantastic. So that wraps up the July Digital Health Access and Equity Symposium. Thank you all for joining us. And if you want to attend the August one through an auto enrollment, just click on just type yes in the chat box, and we will have one of our folks in the production team auto enroll you for the August symposium. And in the meantime, we're looking forward to seeing you all again there soon. And we also want to say special thanks to Digital Diagnostics for their funding of this program today. Remember, it is AI the right way, and that's very important. Very special thanks to all of the HitLab production team for putting this together today. A lot of work goes into this, from Rachel Fredman on the marketing and comm side through Yamina and Raymond and Jess, Kevin on the design and video production side, and then all of our terrific folks working on the social media side, including Ayana, Ava, Ashika, Christine, and then of course our captain, the production director, Jerry Antomato. Thank you everybody for joining us today. Have a terrific rest of the week and rest of the month. We will see you in August, and we will be talking about how we bridge the information gap and then continue talking about the data access and leverage there with everyone from Vicert and their CEO Voya to Nardo and Catalyze, and obviously our fearless leader, the chairman, Bill Taranto of the Merck Global Innovation Fund, and Lisa Crimes from HitLab. Thank you, everybody. Looking forward to seeing you in August. Please do keep us in touch and let us know if you have any other ideas and for speakers and topics to cover in the next several months of the symposium. Take care and stay safe. Bye-bye.